Hello, everyone. Welcome to join the APSC CME Webinar. Today, the webinar was organized by APSC Subcommittee TCIP, Transcontinental Coronary Imaging and Physiology Club. The focus of today is Advanced Imaging Guided Calcium Management in PCI. The program was endorsed by Singapore Cardiac Society and was accredited by European Board for CME, and this program was in collaboration with APA. Before the webinar, we have to declare some disclaimer and housekeeping. The content of this webinar is copyrighted by the APSC, and the view and opinion expressed are those of the faculty members and do not necessarily represent those of the APSC. And for the whole CME program, you are welcome to have Q&A. You can just type on the chat. And for TCIP, actually is a group of friends who has special interest on imaging in physiologists all around the world. We come together to focus on education and scientific research. And today's program, this is overview, is a very exciting program because it's not a usual calcium management. It's some demon level, very advanced level of calcium management. We will go through it bit by bit. Today, we are very honored to have 4 moderators to chair this relatively long and exciting sections. The moderators include Dr. Chee, Dr. Johnson, Dr. Lee, and Dr. Lucio. They are all our good friends. And the program, these are the renowned cardiologists in different regions in Europe, Australia, Asia, and South America. And they will be introduced by the moderators in details later. So today I will hand over all the things to our moderator, Dr. Zhen-Vin Lee, who is the consultant interventional cardiology in the famous center, University Malay Medical Center in Malaysia. So Dr. Lee.
Well, thank you very much, Dr. Lam. So today it is going to be all about calcium, and calcium increases procedural complexity as well as significantly impacts on long-term patient outcomes. So for the purpose of going deep into the management of calcium, I'm honored and proud to have with me today my friends and colleagues from all around the world who are expert operators and have contributed immensely to the field of interventional cardiology. So to kick things off, I just wish to state that there will actually be 2 parts to this particular session today. The first part will we will have 2 12-minute lectures, followed by 8 case-based presentations. And after each presentation, there will actually be a 5-minute discussion. So I wish to now invite everybody to ask as many questions as possible throughout the whole session, and we will definitely try to address all of them. So for the first session, we will start off with a presentation by Dr. Chiang Chin, who is at present a consultant at the National Heart Center, Singapore. His predominant interest is in intravascular imaging and physiology, and completed a fellowship in intravascular imaging at the CRF as well as Columbia University Medical Center in New York. He also has special passion in teaching and is very active in medical education. So Chiang, would you like to kindly present your talk titled Assessing Calcium by IVUS and OCT? The time is yours.
Great, thanks. Thanks, Zhen-Vin, for that. So it's, welcome everyone. I think today we have a very packed program, so I'll not waste any time. My talk is going to be on assessing calcium by intravascular imaging, both IVUS and OCT. This is what I'm going to try and cover in the next 12 minutes or so. So firstly, we will go through the limitations of angiography and calcium assessment. We revise some of the basic imaging features of calcium as seen on OCT and IVUS. We try and familiarize ourselves with the imaging-based calcium scoring systems, again, both OCT and IVUS, and then try and really understand how we can use these imaging findings strategize our PCI approach to calcific lesions. So I'm just going to start off with this slide that basically shows that, although we think that we can see calcium on angiography, we do miss it a lot of the times. And if we use imaging, such as OCT or IVUS, we can see a lot more calcium, which we sometimes might not be able to appreciate on angio alone. Of course, with angio, we have ways of scoring the severity of calcification, but certainly nothing as robust or nothing as granular, if you like, as the ways we can do it with OCT or IVUS. So with imaging, we can describe calcium in many different ways. We can distinguish whether it's deep calcium, concentric calcium, eccentric calcium, nodular calcium, etc., etc. And with angio alone, sometimes it's very difficult to do this. And obviously with imaging in the last few years, due to its ability to assess calcium a lot better, we have these so-called calcium scores, which we'll go through later, which help us predict what kind of lesions or what kind of calcific lesions will be particularly difficult to get a good result with. So just to go through some images, since this is an imaging, supposed to be an imaging orientated session. So on IVUS, I think hopefully many people will already be aware, but calcium tends to look very bright on IVUS. It's because ultrasound waves bounce off calcium, so calcium reflects almost all the ultrasound waves that hit it. So as a result of that, the surface of the calcium tends to be very bright because all the ultrasound waves get reflected back to the transducer. And because nothing or hardly any ultrasound waves can penetrate through calcium, we get signal loss behind the surface of the calcium. So we can't see behind the calcium. So it normally looks dark behind the calcium. So we look at these images here and we contrast what fibrous plaque normally looks like on IVUS. You get a homogeneous kind of appearance of the plaque. You can make out the media layer. You can see beyond the plaque. But with calcium, we only see the surface of the plaque. It's very bright. It's very easily distinguished, but we cannot see behind it. With OCT, light or infrared light can penetrate through calcium. And because of this, we can usually see the thickness of calcium. Calcium normally looks hypoechoic on OCT, so it should look a little bit darker than fibrous tissue. We should be able to make out the margins or the borders of the calcium plaque very easily. So if you use a pencil, you should be able to trace out the calcific plaque. And in most cases, we should be able to see the deep border of the calcium as well, and in so doing, make out the thickness of calcium. So the main difference, I would say, between IVUS and OCT in assessment of calcium will be is the ability with OCT to determine the thickness of calcium. And just to show how this might be of use, if you look at the image on the left, you have an eccentric looking calcium bright surface on IVUS, but we don't know how thick this calcium plaque is. With OCT, we can penetrate through the calcium and we can see whether it's thick calcium or whether it's actually thin calcium. And of course, this has implications on how easily this lesion might be able to be prepared. Just to go through some other images or some other descriptions of calcium, which I'm sure you're going to hear a lot during today's session. Firstly, superficial versus deep calcium. So superficial calcium is calcium which is very close to the lumen, almost in contact with the lumen, such as here on the left panels. Whereas deep calcium is calcium where there is a thickness or a layer of tissue, usually fibrous tissue, between the calcific plaque and the lumen. So the calcium is not directly in touch with the lumen, and this has implications if you want to consider things like atherectomy. Concentric versus eccentric. Concentric usually means a circumferential of 360 degrees kind of calcium, whereas eccentric is anything less than that. Another term that we might hear is napkin ring. Napkin ring basically means a concentric area of calcification, which is also very tight, such as in this example over here. And also in this example over here, we see what we call reverberations. And reverberations are these multiple echoes of the calcium surface. So these lines that we see behind the surface of the calcium are not actual structures that the IVUS is seeing. It is kind of, I guess, an artifact as a result of the multiple reflections between the highly reflective calcium surface as well as the IVUS catheter, and it gives rise to these echoes of the same image. calcified nodule. We have a talk on calcific nodule later on. I'm sure this subject will come up a few times. A calcified nodule basically is an area of nodular calcification that protrudes into the lumen. So unlike the normal kind of calcium plates that we see, a calcific nodule or calcified nodule normally protrudes into the lumen. It is normally associated with thrombus and fibrin on its surface, and that gives rise to the attenuation that we see on OCT. And usually it's in an area with a lot of calcium, so there should normally be an underlying calcium plate as well. I'll just show you a pullback here of what an IVUS picture of calcified nodule might look like on a pullback. Here you see a plate of calcium, and as we pull back more proximally, you can start to see that the surface becomes irregular. There seems to be things protruding into the lumen. It's bright, so that's calcium with a bit of a thrombus on top of it as well. So that's a calcified nodule, as you might see on IVUS. Here on the right, on OCT, again, we see that there's already a lot of calcium. And then around about here, just focus at the 10, 11 o'clock area, we see that there are these little protrusions. It almost looks like thrombus. In fact, it is thrombus. It's thrombus on top of the calcified nodule, and that gives rise to the signal attenuation that we see on OCT. Now, in terms of the calcium scoring systems, the OCT calcium score came out a few years ago. Basically gives us an idea of how likely we are to end up with an underexpanded stent. So the OCT-based calcium scoring system comprises 3 elements. Firstly, the maximum arc of calcification, the maximum thickness of calcification, and obviously the total length of the calcified lesion. How to remember these points? You can use the so-called rule of 5s. So if you've got an arc of more than half or more than 0.5 of the circumference, which is 180 degrees, you get 2 points. So maximum arc calcium more than 180 degrees gives you 2 points. Maximum thickness of calcium of more than 0.5 millimeters or 500 microns gives you 1 point. And a total length of more than 5 millimeters gives you another point. And if you score 4 points, so if you have all these 3 elements, then you are at high risk of stent under expansion, because the calcium lesion is more likely to be difficult to be well prepared. And so you really need to, or really ought to, pay more attention to your lesion preparation. And you might want to consider the use of these adjunctive devices like atherectomy or lithotripsy. The IVUS calcium score is somewhat similar, but comprised of different elements. For the IVUS calcium score, we look for calcium that is more than 3 quadrants, so that more than 270 degrees, for 5 millimeters or more in length. So if you have a longish lesion of more than 3 quadrants of calcium, that scores you 1 point. If at any point you have concentric or 360 degrees calcium, you get another point. If you have calcified nodule in your lesion, that's also a point. And if your vessel size, if your vessel size at that area of calcification is less than 3.5 millimeters, that scores you 1 point as well. If you have a score of 2 or more, then again, like OCT, like the OCT scoring system, you're at high risk of stent under expansion, and you might want to consider atherectomy or something else like lithotripsy to really better prepare your lesion. What else can imaging do in terms of predicting events or predicting complications in calcified lesions? IVUS may be able to predict slow flow after rotational atherectomy. And the factors that might be associated with slow flow after rota include a long lesion length, the number of reverberations. Yeah, the more reverberations there are in the lesion, the more likely you are to have slow flow after rota. And if the arc of calcification is greater than 300 degrees, that is also kind of a risk factor for slow flow after rota. Now, is knowing where the calcium is really important? Yes, and as described by Dr. Kenichi Sakakura, who is one of the most published authors in rotational atherectomy. These are some of the ways in which IVUS may influence how you approach atherectomy in particular. So if you have a circumferential or a napkin ring kind of calcification, then these are kinds of lesions that would be ideal for atherectomy, because your burr is more likely to be able to affect the calcium. If you have deep calcification like this in example B, then atherectomy may not be so effective because you're not going to be able to get in touch or get in contact with the calcific plaque because there's a layer of fibrous tissue in between. So atherectomy may not be so effective in this kind of situation, and you might want to use a balloon instead. If you have images of scattered calcium, such as this, where the calcium is not continuous around like a napkin ring might be, then usually a balloon or a high-pressure balloon should be able to dilate the lesion along the cracks. And if you have eccentric calcium, and eccentric calcium is probably one of the more difficult kind of situations to get really good lesion preparation. If you have eccentric calcification, then really IVUS can help you predict whether your atherectomy is going to be effective or not. And this may be one situation where you might want to change your wire bias, or you might want to use some other devices like a lithotripsy. So just another slide about how atherectomy can be better directed. I'm just going to go very quickly here because I think Tom Johnson might speak about this as well after this. So if you look at these examples, on example A, this is circumferential calcium. It's tight. The imaging catheter is in contact with the calcium plate. So most of the time, the imaging catheter and the rota burr should take the same wire bias. So if it's in contact with the calcium here, you would expect the rota burr to also take the same path. So if it does this, this is your atherectomy, especially rota, should be quite effective. If you get eccentric calcium like here in example B, where part of the imaging catheter is in touch with the calcium, but a lot of it is in touch with fairly normal or healthy vessel, then you might want to be a bit more careful about your atherectomy, because if you're overly aggressive, if you take too large a burr, you might cause some damage on the normal part of the vessel instead of just affecting the calcium. And if you have eccentric calcium like here, where the lumen is relatively large and your IVUS catheter or your imaging catheter is not really in touch with the calcium surface, you might want to change your wire bias to either you change your rota wire to try and affect the wire bias so that it brings your burr closer to the surface of the calcium, or you can use a larger burr. So these are just some examples of what IVUS images might look like before and after rota. These are the same, they are co-registered segments before and after rota. Here you can see that there's a lot of calcification, concentric, and after rota, you can see that there's this like a chunk taken out of the calcium. Yeah, that's where the rota burr has traveled. So this is what you might see after rotational atherectomy. You get a bit of a luminal gain. Here, again, you get some luminal gain. You see some cracks in the calcium as well, which is obviously what you want to see after ballooning or atherectomy. And also we see some reverberations, which have apparently been described as also good indicators of effective lesion preparation after rotational atherectomy. So in summary, I think we will all agree that calcified lesions remain one of the biggest challenges in PCI today. OCT and IVUS calcium scoring systems have been developed, and these allow us to objectively assess calcium severity and to predict procedural difficulty and complications. And I think overall the message should be that intravascular imaging allows better assessment of calcium distribution. It informs the strategy for effective lesion preparation, and I think it really does enhance procedural safety. Thank you very much.
Thank you very much, Chee, for the very comprehensive lecture. At present, we do not as yet have questions from the audience. So while we wait for questions, perhaps I can just ask you one. I think in comparison of both modalities between IVUS and OCT, the key difference here would really be the depth of the calcium, which is oftentimes more favorable with the OCT. I was just wondering if with the newer generation or 60 megahertz IVUS, would that actually be better? And would that actually solve the problem with the current generation of the 40 megahertz catheters in terms of the depth of calcium, and would it give you a more accurate assessment?
I think the simple answer to that would be no. I think the general principle or general attribute of ultrasound is that it is reflected by calcium, and I don't think changing the resolution or the frequency of the ultrasound wave affects that. In fact, if you have a high resolution or higher frequency wave, then your penetration actually becomes less. So short answer to that is no, I don't think so.
Okay, because it always is a trade-off, isn't it? I mean, a lot of these patients with extensive calcifications concomitantly have CKD as well. So sometimes whilst we are actually aiming for better assessment, we are probably limited by the fact that they have kidney disease, and we are restricted to using the IVUS as well. So that is probably an issue here. Okay, so now we have a question, Chia. The question is, will orbital atherectomy or electrotripsy be useful for deep-seated calcium? I think we have a session on this, but probably since you brought up some of the pointers, you might just want to give a quick answer to this as well, whether OA or electrotripsy would be useful for deep-seated calcium.
Yeah, I think again, in theory, if you have fibrous tissue between your lumen and your calcium, then these atherectomy devices will not be able to get to the calcium. And if you if what these companies purport to be is true, in that there should be differential cutting. So if your burr touches fibrous tissue, it shouldn't cut it, right? That's how they promote the whole safety thing about atherectomy. So if that is true, then your atherectomy burr or crown should not be able to reach the calcium. So I don't think it will be as effective as if it was superficial calcium. Lithotripsy probably is different. I think theoretically it might should still be able to get to the calcium. I don't know if it will be attenuated somewhat by the tissue in between. Yeah, but I think because it works in a different mechanism, I think in my limited understanding of it, probably will still be able to affect calcium. I don't know if anybody else wants to comment on this.
I think, Tom, you've got some comments to make.
Yeah, well, firstly, a beautiful presentation, fantastic start to the session. I think, so what interested me most from your presentation was the before and after imaging. And I think what that throws up is both the beauty of imaging detecting calcium, but then the challenges that we are now embarking upon in terms of interpreting the imaging and knowing how much modification is enough. So you've shown rotational atherectomy predominantly in that presentation. And for me, there's obviously a debulking kind of process there. But obviously IVL is looking, we're now talking about vessel compliance and allowing for the vessel to expand and a stent to deploy. So I wonder how frequently are you using imaging both before and after your modification? Because I don't think that's done by the majority. It's done by me, but the reason is to emphasize that point, really.
Yeah, I think that's quite right. Again, it could be because we are more familiar with it and therefore we use it more. But certainly, I think if you've got the catheter out, especially if it's IVUS, no disrespect to OCT, but with IVUS, you don't need to expend any extra contrast. So if you've got the catheter out, my practice is to use it as much as possible, to really get the most out of it. You spend a little bit more time maybe, but if you see something that requires more action, then that might save you a lot more time later on.
I think that's a great point, because if one were to just do pre and post, as in pre-stenting and post-stenting, without looking at the after effects of any form of debulking, well, technically, if you're just relying on angiography alone, that would actually be a wrong move, I guess, because you really need to understand what the debulking device has done to your calcium in order for you to know whether you have got more work to do, etc. So I think, okay, if there are no, okay, Dr. Sidney, you have got a comment to make?
Yeah, so I think Tom's point is well taken. So the other thing is that if you're doing the imaging before and after your initial plaque modification and decide that you need to do more, The only way you know you need to do more is if you've imaged. The only other way is to try to sort of dilate with an NC balloon and look at many different views and think you may have gotten some sort of expansion that's reasonably adequate, but it may not be optimal. So the imaging will tell you a lot about how much modification, and maybe continue to modify some more prior to stent implantation, and then the actual stent expansion at the end.
Well, thanks, Dr. Zhen-Vin, for those great comments. So I think if we do not have any further comments, probably we shall now move to the second lecture, which will be presented by Dr. Thomas Johnson. He is at present an associate professor at the University of Bristol. He's also a consultant at the Bristol Heart Institute, has published extensively and sits on many scientific committees involving interventional cardiology. So Tom, the time is yours to present your talk on optimizing atherectomy and IVL with imaging.
Thank you for the invitation, and thanks to Dr. Lam for putting together such a fantastic session. It's a real honor to take part in TCIP. So optimizing, the title is Optimizing Atherectomy and IVL with Imaging. Actually, I've taken atherectomy as both being debulking, so actually we'll show a case of Orbital because it's technology that we've just recently adopted, and it's then interesting to consider kind of mechanisms. So in terms of imaging, there's some interesting data that actually comes out of Abbott. This is the Light Lab initiative that was presented just a couple of years ago, and now there are more publications coming, led by Abbott and Kevin Croce, Ziad Ali participating. And this was an initiative where 12 centers across the states had a field technician embedded into their cath lab workflow, with a view to then trying to observe and witness how imaging from the start to the end of cases made a difference. Now, specifically, just focusing on calcific lesion, there's some really interesting findings that come from that. So we see that in about half of the cohort of just over 250 patients, that there was a change in device. Now, actually, in part, that reflects, I think, on American practice, which is an interesting observation, where actually a very significant proportion of patients were going to receive a direct stent with no adaptation of vessel or assessment of lesion prior to implantation. So half of the half that changed strategy were just simply going to get a compliant or non-compliant balloon to palpate the lesion. And then we see a stepwise increment in terms of complex modification with cutting or scoring or atherectomy laser. In around the roughly quarter of patients where the imaging didn't change the decision-making, we see that the vast majority had some form of balloon palpation, but a significant cohort, 10% had atherectomy or laser, a further small 2% had cutting or scoring balloon use. But if we take that as a whole, actually we see that there's almost a 10-fold change with the use of upfront imaging from a 3.1% use of more advanced modification techniques to a 27% use. So the identification of the calcium plays quite an important role. Now it's interesting for us then, for me personally, to reflect on our practice in Bristol, and this is just a few years, just 4 years of our rotational atherectomy use. We do around 1,900 to 2,200 cases a year across this period. So a relatively small proportion of cases we're utilizing rotational atherectomy. And we see that the orange, which is atherectomy plus imaging, predominantly IVUS, we see that there was a significant shift 2018, 2019 to the majority starting to have imaging use. And really that came about with the arrival of intravascular lithotripsy, where we as a team agreed that we were going to image and better understand the nature of the calcium, as beautifully highlighted in the last talk, so that we then understand then further how we're actually modifying the disease prior to the implantation and optimization of our stents. Now, if we look at this as a whole, this is now broken down into 6-month periods, we see that there has been really an increment in our usage of modification, albeit COVID kind of impacts on numbers to the far right of this graph. But what really I want to stress from here is that we do see that actually with the advent of new technology, that we start to see cases where multiple adjuncts are needing to be used. It's not that we take rota and that's it, or we take intravascular lithotripsy and that's enough. There are a proportion of cases where we have to consider more than one modality. But if we think about tools in turn, then I think they each have a key characteristic. So if we're talking about an uncrossable lesion, then it may be that we turn to laser, not a tool that we currently have in our toolkit, I must confess. If we're looking at high burden, or we've heard earlier about nodular calcium, then we might be thinking about some form of debulking, either rotational atherectomy, where we see them beautifully, the coring out of a channel by use of our imaging, or rotation or orbital atherectomy, where potentially we get this sanding effect, and they would argue also a fracturing effect from reverberation of the device. Or if we're faced with circumferential calcium, we may think about some form of ballooning technique, either simply moving to a cutting scoring balloon, or perhaps to a more advanced and costly technology like intravascular lithotripsy, where then again with imaging we can see gratifyingly fracture, and we talk about an increased vessel compliance for the purpose of receiving the stent and then ensuring adequate stent expansion. Now that means actually we've got quite a lot of decisions to make, and I think what that leads on to is this idea of taking an algorithmic approach. And this, for me, I think is the most elegant of the algorithms that have been described to date. This comes from a kind of collaborative effort between James Spratt and Margaret McIntaggart alongside vascular perspective education. And I'll take you through this in turn. So we've already heard that there's a difference between angiographic assessment and imaging assessment. And this is a beautiful study of a cohort of patients that underwent angiography, IVUS, and OCT. And what we see is that we had an overall cohort of 400 patients. Less than half identify a calcification by angiography, albeit we must acknowledge that those that we recognize are probably the most severe and therefore those most likely to require modification of some kind. But it's not a definite predictor. If we look at OCT, and we've seen how OCT can both give us presence of calcium but also thickness of calcium, we see that a far greater majority of patients are identified. But interestingly, actually, IVUS represents probably the most accurate form of detection of calcium. And this is partly through the fact that thrombus tissue in the presence of deep wall calcium, those other tissue characteristics can obscure our awareness of calcification by OCT. Now, if we consider actually the burden of calcium, this is now a head-to-head comparison of IVUS against OCT. We actually see very, very striking correlation between the two. But as we've already acknowledged in the last talk, OCT does give us this ability to also detect thickness, which is an important metric for prediction of stent under expansion. So if we move through the algorithm, we look at angiographic assessment. It may be that you just take a balloon and you palpate. Now, ultimately, we may be faced with actually an uncrossable lesion that you're unable to deliver any device, in which case actually we are going to turn to rotor or laser atherectomy to try and facilitate passage of devices. Now, I'd argue that the algorithm needs slight adaptation. And actually in my practice, if I can, I will look to image up front before passage of any other device, because it may well be that in understanding the nature of the calcium, I may want to take an upfront device rather than ballooning to achieve perhaps better debulking. So in the setting of high burden calcium, my anxiety about taking a 2mm balloon may be that I then lose the potential for contact of my rotor device against the disease. So upfront imaging for me has potential benefit in selection of device, in part maybe minimizing vestal injury before making a decision. And we've already heard very nicely in the last presentation about this consideration actually where we see where the imaging catheter sits within the vessel. The bias of the wire and the device gives us some idea about how other devices may interact when we come to utilize them. So the imaging is important then obviously in assessing our calcification. And we've already heard very clearly that there are elements that we need to understand. The arc, if it's less or greater than 180 degrees, the nodularity, the thickness, and these may all then determine the selection of our device. I think the qualitative assessment of calcium is actually something that is currently overlooked. And we see from this nice series of acute coronary syndrome patients with calcific plaque, thankfully a relatively small minority of an overall cohort of ACS patients, we see that there are these different qualitative types of calcification: the superficial concentric sheet, the eruptive calcific nodule, the more nodular protrusive calcium, which actually in my mind is the scariest calcium for us to deal with, because I think this is where actually we're associated with a far greater hazard intraprocedurally, particularly of perforation. We've already seen these metrics in terms of quantitative assessments, so I'll skip across that quickly. But if we now take the top panel, we're happy, we have the uncrossable lesion that we're going to consider debulking. If we made an analysis and we actually have an arc that's less than 180 degrees, then we may just simply take a balloon and palpate the lesion. We may advance up to OPN or cutting balloon to see if we have concern about expansion. If we're faced with nodular calcium, then it may well be that we will use rotor in an attempt to shave off the nodule. And actually now, I know that Orbital has been available in other territories much longer, but in the UK and Europe only very recently has this been available. Then actually Orbital may be a tool that we would like to facilitate. And then if we're faced with the much greater, greater than 180 degree arc, greater than 500 micron thickness, then intravascular lithotripsy is really probably the simplest approach to trying to adapt the calcium there and then. Now, what James and Margaret done here is they've actually added now to the algorithm with additional considerations. So if we're looking at actually a lumen that retains a dimension of 2 or more, then potentially we have to think about different adjuncts. If we're faced with an ostium or left main lesion, again, we might choose a different tool, and in the setting of complex bifurcation. And so in this setting, it may be, again, we use balloon when we're faced with slightly lesser burden calcium, but in the higher burden calcium, really for these additional characteristics, IVL seems to be the preferential device. Now, the next element, and I think the most important, as we acknowledged in the questioning of the last presentation, is really this fact that you take imaging again once you've taken these adjunctive devices to really assess whether there is or is not modification. And if there isn't evidence of modification, or I think more challengingly, if we feel that the modification isn't sufficient, then we have to return to the earlier part of the algorithm and consider further device or repeating the device that we've already used. Then beyond that, once you're comfortable, then we may further palpate the device one-to-one with the non-compliant balloon before placing our stent, at which time then we're looking to achieve certain metrics of adequate expansion. There's been this kind of a focus upon a minimal stent area with an absolute value of 5 or 5.5 by Ibis millimeters squared. I think probably we will turn more to look at relative expansion, and maybe an 80% expansion is realistic in this very challenging disease subset. So I'll show you a quick case if I've got time. This is a relatively recent case of a patient who actually was presented under one of our grown-up congenital colleagues for a right and left heart cath and was found to have this significant lesion. One of the interventionists was called in to say, why don't you just treat the right while we're here? And lo and behold, actually this right coronary proved to be very challenging. They hadn't been adequately set up, but actually passage of devices was very difficult. And so they were rescheduled for another procedure in the knowledge that things had been difficult. So we see a more aggressive guide catheter, an AL 0.75, 7 French from the radial. And then we see this tortuous disease, which actually led us in our early experience with Orbital to consider that Orbital here may be the preferential device. So here we see passage of the orbital, the first cross of the orbital. So it is a 1.25 millimeter device with the crown, as you can see, that's in a non-symmetrical pattern, kind of attached to the catheter. It actually delivers remarkably well across the Viper wire, and we see the first passage. There's then a lot of focus, mainly driven by the acoustic nature of how this device is interacting with the vessel. We're sort of focusing around the mid-vessel for passage of this. Now, as we've highlighted, the important thing for me here is then to take OCT or take the imaging to then make an assessment. And this is just to show you the new Ultron software, where actually we have an automated detection of calcification. So I've just reduced the display to 180 degrees. And so we can see in orange here, areas of the vessel. We're working proximal to distal in the new Ultron software. We see areas of very marked calcification. On the right-hand side, you can see the arc and the thickness, which have been automatically detected by the software. And now, interestingly, we come to this area of mid-focus, and you can see very clearly then actually a 1.2 plus millimeter curve, which is where the orbital device has actually interacted with the very high burden calcification. So what's really interesting there is to see actually the interaction of the device with the vessel is perhaps different to how we might have considered conceptually in terms of it taking this orbital track. And so what we see then is actually that it seems to have, rather than circled the vessel and debrided or sanded the vessel, it seemed actually to have kind of got quite busy and to have worked its way into creating a channel. So I guess the next question then is, having seen this, we still see very high burden plaque. We talked on that algorithm about the additional characteristics of having a 2 millimeter more lumen, but presence of very high burden calcification, that we might have to turn to a different device. And so actually at this point, we felt that we hadn't achieved adequate modification, although with 10 runs of the orbital, we'd clearly caused some debulking. And so actually we went on and ballooned both with a 3.5 non-compliant and then aggressively 1-to-1 with an IVL, which interestingly burst on the 4th or 5th train of 10 pulses in the proximal vessel, highlighting still very aggressive calcification. So we went back at this point and repeat an OCT to further assess whether we've got adequate fracture. And so we see nicely here now in the proximal vessel where we saw balloon rupture, we see that there is quite kind of spiculated, angulated calcium, which might have led to the balloon fail, but we see importantly fracture. We see actually quite a lot of vessel trauma. So here we see the intima hanging off the deeper vessel structure. And actually at the point of greatest stenosis in the mid vessel, which had been our focus, we see again these very characteristic IVL fracture points. And then gratifyingly, where we created that orbital channel, we've actually seen that open up now, and we see then the vessel compliance change. So as I alluded to earlier, I think this need of maybe multi-modality approach to the most aggressive calcium is going to be the way forward. So at this point, we placed devices, 4 millimeter stents are placed, and we see finally that we've actually achieved really very gratifying stent areas closer to 10 millimeters squared than the threshold of 5 or 5.5. And we've just about achieved an 80% expansion. This is driven actually by the very large size, the ostium of the right coronary. I think we should agree that this is a decent result. And here's the final angiographic result. So I'd conclude that imaging is, I think, central to an algorithmic approach. Calcium identification is undoubtedly enhanced by our use of imaging. We have these quantitative metrics for identifying those vessels that might need more aggressive modification. Qualitative assessment, I think, is more nuanced, and that's where I have, I think, a tremendous amount of learning to continue, and that's sorts of meetings are so important. And then beyond that, I think there is a question about what tool are we selecting for what purpose. We're looking at debulking, we're looking at fracture, we're looking at this concept of enhanced vessel compliance, and I'm not sure yet actually which tool is right in which setting, and I think that's something that we need to continue to learn. I thank you for your attention, and just really focus on the idea that we use imaging to identify, modify, and optimize throughout our procedure. I look forward to some questions.
Thank you very much, Tom. That was a great lecture. Definitely extremely comprehensive as well, going through the whole algorithm of calcium debulking. So I'll just briefly start off by asking you a simple question, because you've actually presented a case with multimodality sort of approach with orbital upfront followed by IVL. So we would, of course, conventionally start off with the lower speed at 80,000. So what would be your personal selection method to decide that from the OCT you would actually switch out immediately to an IVL, or we would actually go up to 120,000 first and then decide and take it from there? Because of course the multimodality method is actually a way moving forward, but an additional device would mean that the cost would actually increase as well. So what's your take on that?
No, I think that's a really important reflection, is that I'm in a fortunate position where we have all the tools, and actually cost doesn't tend to play a part in our decision making. But undoubtedly that is an important factor to consider. As I said, I'm not sure that we know precisely how we should be interacting with choice of device and choice of multiple devices. The reason that in that situation we went from having been really quite persistent with CSI to then choosing a different device was having seen the way that that device had interacted with the vessel and had created the channel. And actually my worry then, and having listened to the device, I'm sorry I can't share with you the kind of noise of those interactions, is you worry that you're actually going to drill and drill and drill, and at what point does that stop? And although I think debulking plays an important role, what's interesting is I don't think we have control over exactly how we can debulk in that scenario. So for me, actually, it was safer and more important to take IVL at that stage to try and achieve the final goal. And I think there is that balance between achieving perfection and also balancing that against safety. And one of the things that IVL, I think, has pushed very hard is the safety of their device. And undoubtedly, taking a balloon, inflating it to 4 and then 6 atmospheres and palpating the lesion, it is going to clearly have benefit over some of the other more aggressive devices.
Thanks, Tom. So in relation to the point that you made about having a threshold for safety, what would be the imaging sort of an assessment that you would definitely say enough is enough? I mean, let's just use atherectomy as an example. Are there any imaging guidance for you to provide to our audience today that, after atherectomy, if you were to see some findings and you will definitely stop there?
Yeah, if anything, I'd say from my experience that the risk of imaging is possibly that you pursue for longer and maybe you're more aggressive and maybe at greater risk of causing harm. So I have a collection of cases where I probably have pushed too hard simply because I've been so intent on achieving a perfect result. And so if anything, the argument is probably to take a cautious approach and think about the mechanisms. I think what's intriguing about CSI for orbital atherectomy for me is that I haven't seen very many sessions where people have actually dived down into looking at the imaging. And that for me suggests that either we're seeing things that we don't want to see, or we're not seeing very much. And in our early experience, and we really are in a relatively early part of our learning curve with orbital, we've seen some really interesting findings. You talk about low to high speed. What I've seen with the high speed is actually that we're putting the vessel under quite considerable stress. And in areas where you don't have concentric calcification, seeing quite aggressive dissection at the interface between soft and hard tissue. So I think we need to be doing more in terms of imaging to understand the interaction between vessel and device, and each and every device in turn, to understand actually how we're going to implement those algorithmic approaches, because I don't think we know yet.
Sure, thanks, Tom. Dr. Lucio, you have a comment to make?
Yes, this is a very nice webinar because we are looking forward all the disease of calcified disease by images. But we have a really for example, in Latin America, and that not all the people have images, have IVUS, OCT. For example, in IVUS have most or less 42% of the people, and OCT 3% of the people. So first of all, Thomas, we know that the images give us and assess the calcified lesion very well in order to have better results, less perforations, less complications. But do you think we can do calcified lesions, this type of calcified lesion, without images? Because, and with this, can we do, or is better to do with the ABC will be no compliant balloon, and then to choose between ROTA and IVL? Or what do you think will be the approach for people without images?
Well, I think the reality is that the vast majority of cases globally are done without imaging. So I mean, the quick answer is yes. And I guess, there are adjunctive tools that we can use to assist. So, the clear stent technologies actually can be very good at demonstrating calcium. So placing if you're in the position you can cross the lesion, place a balloon and actually take a clear stent to try and get an understanding of the burden and the concentric nature of the calcification. And then clearly you're really going to only be able to interact with how the balloon devices behave within the vessel. And again, I think one of the very simple teaching points, which is often overlooked, is when you've got a balloon inflated in a heavily calcified vessel, make sure that you assess it in orthogonal projections. So don't just wed yourself, just work in a single projection. Ensure that you flip between orthogonal projections to be sure you're not missing an eccentric underexpansion of that balloon. And then undoubtedly, if you're in a position where you can cross, then IVL has huge kind of promise in terms of being an easier, safer, shorter learning curve device, and is therefore going to be the device used by the majority. Although cost will be the deterrent, as it will be for every adjunct, I think.
Sure. Thanks, Tom, for those great comments. It has been a great discussion, but in the interest of time, I think we need to move on. So perhaps, Chee, you can introduce our next speaker.
Yep. So now we move on to the case presentation part of the evening. And first up will be Dr. Vincenzo Vizzi, who is a senior cardiology consultant in Milan. Like many of us, his area of interest is in complex and high-risk procedures, as well as in intracoronary imaging. And his topic today will be a master case in Shockwave PCI. Please go ahead, Vincenzo.
Hello, everybody. Thank you very much for having me here. Thank you, Dr. Lam, for the patience of organizing everything. Can you see my screen?
Yes.
Okay. Sorry, I'm trying to get rid of the Zoom panel. Okay. Well, fine. So I apologize for that. So we all know about the, we already discussed about the common current indication for AVL, which goes from the treatment of superficial 360 degrees calcium, or as demonstrated recently, a safe and efficient treatment of underexpanded stent. But when it comes to calcified nodules or eccentric calcium, well, the debate is still on, especially when we do not have a circumferential calcium. Although there are some data coming from Disrupt CAD, where apparently IVL is as effective in eccentric and concentric calcium. So I hope that this case, I'm going to show you, we're going to generate a debate about that. So this is a 66-year-old man, diabetic, hypertensive, obese, who had a previous PCI with drug-eluting stent in the mid-distal RCA in 2016. He came in with a return of typical angina currently on CCS3 in the last month, despite optimal medical treatment. He has a normal echo, and he was admitted again for elective angiogram. His left coronary system is actually unremarkable, with only minor disease. While the right coronary artery, which is a huge superdominant coronary artery, has got this subtotal occlusion in the proximal ostium part of the vessel, heavily calcified, as you can appreciate from just the angiographic point of view. The stents put in the mid and the distal RCA were widely patent. So my plan was to try to make it as simple as possible. So what I did, so I was radial, 6 French guiding catheter, Judkins right. I put a workhorse wire down to the posterolateral branch, and I tried to palpate the lesion with a Tazuna 1.25 millimeter balloon, which actually worked well. That was done because I felt that I could not pass the IVUS catheter up front. The plan worked well, so I managed to perform the IVUS. As you can see here, the IVUS confirmed what the imaging, the angiographic imaging showed. I like to call it a tsunami of calcium going into the lumen of the vessel, where you can appreciate both the plate of eccentric calcium, which is more than 180 degrees, as well as protruding calcified nodule, as you can see here. The disease, the calcified disease, goes back up to the ostium. And the MLA at this point was 2.5 millimeters square. So I followed the already mentioned algorithm, and what can we say? So, well, we are definitely in presence of the nodular calcium. Now, according to this algorithm, nodular calcium treatment is best treated by root ablation up front. But also we have an ostial right coronary artery. We have a calcified angle or more than 180 degrees. And I know that with IVUS, we cannot well tell in comparison with OCT about the thickness of the calcium, but there are data suggesting that if there are no reverberation and if there is acoustic shadow behind, we can, this correlates well with the OCT finding of thickness of more than 1 millimeter. So I decided to go with IVL, and I'm not alone in this world, because for example, in this algorithm made by the group of Javier Escaned in Madrid, in their experience, if we have a protruding nodular calcium, then IVL can have a good efficient result. So I've decided again to keep things simple, and I performed 80 pulses of IVL with a 3/0 balloon from the distal part of the disease up to the ostium. And then I have repeated the IVUS to assess my result. Please note that this IVUS was done just after the pre-dilatation with the IVL. Now, honestly, with the typical irregular surface of the protruding nodular calcium, I struggle to see cracks, to be fair. Although it seems that here at this point where there is the where there was the MLA of the lesion, there seems to be some cracks, but honestly, I cannot tell for sure. So how do we? The first question I made, okay, I'm happy with that. Do I need a different calcium modification tool? Well, I thought I wouldn't, because as you can see visually, comparing the IVUS pre and the IVUS post IVL, we already have good luminal area gain. So I decided to go ahead with the angioplasty. I keep running these again because I think it's quite evident. So after further pre-dilatation with a 3.5 NC balloon, I put a stent in the proximal ostial vessel using floating wire technique in order to avoid the geographic missing of the ostium. And I put an ultimastertan safe for row by 24 stent, which was then postulated with a 4.0 NC at high atmosphere. And this is the angiographic result in contralateral projections, which honestly looks fine for me. I repeated the IVUS. Unfortunately, the tip of the IVUS catheter, I was using the Opticross HD from Boston, wasn't able to advance over the first bend where there was the first stent implanted in 2016. So I couldn't see very well the distal edge of the stent for 3 or 4 millimeters. However, the final result showed that in the distal part of the stent, we have a very nicely rounded, well-expanded and well-opposed stent. When we come up to the tightest point of the original lesion, we still have a good expansion of the stent. However, there is a clear eccentric expansion, with actually fits well with the eccentric nature of this disease. Again, at this point, what to do? Do we consider satisfied by this result, or do we need to do something else? Well, I postulated with a 4.0 NC balloon, and I don't think that going higher with a higher balloon, considering that the longest part of this eccentric expansion is about 4, would give help. Also, we know that the eccentric expansion of stents is not clearly a problem in terms of long-term outcome, as long as you reach a good MSA. And in fact, we had a good MSA of 9.2 millimeters square with a 2.5 millimeters square of starting point. So I think that coronary IVL is a very effective tool in the treatment of calcified coronary artery disease. And I agree with what is said before, that intravascular imaging is, I use the term mandatory, but I agree with Lucio's comments, especially when you don't have imaging, you need to do something to select the proper calcium modification tool and then assess the result. Now, the challenge, and I think will be covered again later, is represented by nodular calcium, as there is no clear consensus regarding what is the best way to tackle it. Well, I show this case because I think that in this case, IVL helped to achieve a good final result in a very heavily calcified vessel with a mixed nodular and eccentric calcium burden. So thank you very much.
That's great, Vincenzo. That was a wonderful case. Not only shockwave, also osteal, also calcified nodule. You covered a few topics there. I think I would agree with you that the you know, in terms of the final eccentricity of the vessel on IVUS, I think that's okay. I think the like you mentioned, the final stent area or the minimum stent area is probably a more important predictor of results than the eccentricity index. And I don't think anyone will be able to get a concentric kind of a result here. So I see Dr. Lucio has his hand raised. So maybe we'll just invite one comment or one question here before we move on. So Dr. Lucio.
Yes, Vincenzo and all the guys. I think that what here is, you have done a simple modification plug in an ostial right coronary dominant lesion with a plaque modification with IVL, and you show in the IVUS after IVL some cracks in the ostial calcified eccentric plaque. So I think it's a very good result. It's a very good result of the IVL after a plaque modification with a 1-1 balloon related with the size of the right coronary artery, and the And the stent seems to be very nice. So congratulations. And I think this is the way that if you have only IVUS, you can have and achieve a very good result.
Thanks.
Okay, I think we should move on. And the next speaker is a good friend of mine and my colleague at the National Heart Center Singapore, Dr. Pham Jiang-Ming. He's a senior consultant in interventional cardiology. He has a PhD in and his topic of interest was OCT and bioresorbable scaffolds. Jiang-Ming also obviously has a special interest, like all of us do, in imaging and physiology. And he's going to give us his next talk now on how to deal with non-dilatable or uncrossable lesions. Jiang-Ming, please.
Thanks, Chee, for the kind introduction. Can you all see my slides?
Yes, thanks.
Okay, I'm just trying to maximize to get a big screen as well. Okay, excuse me. So essentially, uncrossable and undilatable lesions are challenging and are commonly encountered in day-to-day PCI, particularly in tortuous and calcified arteries. So they increase the complexity of the procedure, lead to longer procedural times and associated with suboptimal stent expansion. So in the next few minutes or so, I'll talk about an approach to undilatable and uncrossable lesions, share some tips and tricks using some case examples. So balloon uncrossable lesions are defined as stenosis that cannot be crossed with a balloon or microcatheter after a guide wire has been confirmed to have successfully crossed into the true lumen. There are also situations where a balloon successfully crosses a lesion and the operator is unable to dilate it well, such as with a non-compliant balloon, as shown in this right-hand panel. Therefore, the stent cannot cross due to either tortuosity or calcification proximal to the stenosis or in stenosis itself. Now, I'll first focus on an approach to balloon uncrossable lesions, followed by undilatable lesions. We used to think that lesion uncrossability is solely due to calcium. Now, results from this study looks at de novo uncrossable lesions in native coronary arteries that underwent either rotational or orbital atherectomy due to inability of any balloon to cross the lesion, as well as secondary due to severe calcium. Now, as shown in this pie chart here, severe calcium and vessel bands are major determinants of lesion uncrossability. It is that we realize that this interaction of this lesion morphology, as evidenced by the presence of severe calcium, as well as difficult vessel geometry, either by osteolocation as seen in the previous case example, or tortuous vessels that combine and interact to affect the lesion crossability. Now, from this pie chart alone, severe calcium takes up just barely a quarter or 24% of uncrossable lesions. Other anatomical factors associated with uncrossability include that of aortal osteo lesions as well as small vessels. Now, some examples are shown here. A significant vessel band is considered to have an angulation of, say, more than 45 degrees. And generally, as the number of bands increases, the more difficult it is to cross the lesion. Such bands may even impede the passage of low-profile equipment such as the Ibis catheter or the OCT catheter, requiring sometimes gentle pre-dilatation or even atherectomy. Angiographic classification shown in this rightmost panel can be classified from mild, moderate, or severe classification depending on the extent of the radial opacities and whether they can be seen with or without cardiac motion. Other features seen on intravascular imaging such as OCT as shown here. It has been beautifully demonstrated in an earlier lecture. Now, if there is extensive calcium, such as the thickness of calcium is thicker than 0.5 mm, or the out of calcium exceeds 180 degrees, or if there's presence of calcium nodule, this implies greater difficulties that will be encountered when crossing the lesion. So, as the major causes for lesion uncrossability include vessel bands and severe calcium, several methods may be used to overcome these challenges. Broadly, I will group them into methods that will increase either the forward force, we can use a lower profile equipment, or to enlarge the lumen. Operators can start with increasing the forward force by increasing guide support or wire support, or using anchor and balloon techniques. in addition to the use of lower profile equipment, starting use of smaller balloons, followed by the use of microcatheters, and lastly, either balloon-based techniques or laser or atherectomy. Sometimes the operators also need a combination of sequential or simultaneous application of these techniques to result in successful treatment of these lesions. The use of adequate guide support, of course, can make a difference between success and failure. A common equipment used is the guide extension catheter, which allows deep intubation, transversing the calcification and tortuosity in the proximal artery. This increases support and facilitates a large push force at highly resistant calcified lesions, increasing the chances of delivering equipment and successful lesion preparation. Active and passive support can be increased by selecting different shaped guides or those with larger diameters. We can use supportive guides and then utilize backup support from the contralateral wall as highlighted by the asterisk here, and help from the aorta. Furthermore, we can also perform deep engagement of the guide catheter in the coronary artery, which helps to provide active support, although there is a caution that there's potential for complications from dissection and pressure dampening. Now, this is a case example as shown here, involving a tight lesion in an RCA. After routine lesion preparation, the stent could not be delivered due to the vessel bend. Further lesion preparation was actually performed with additional support with the guide extension catheter, and subsequently the stent could be delivered with reasonable angiographic results. Another way of increasing the forward force is to enhance the wire support. The use of extra supportive wire such as the Wiggle wire can help to overcome this problem. The Wiggle wire has several bands proximal to the tip as highlighted and asterisk in the left-hand panel. It works by shifting the direction of the pushing force, either sidestepping or overstepping the obstacle. In this case, it could be a band or a calcium, pushing the balloon or the stent away from the arterial wall, facilitating the delivery. The body wire technique involves passing a second wire through the lesion in order to enhance support. This can help to straighten tortuous bands and reduce friction from the wire bias. An extension of this technique is the wire cutting technique as shown in this right-hand panel. Two guide wires are passed into the distal vessel, and the balloon is actually advanced to the side of the lesion, abutting this uncrossable segment. The balloon is then inflated during the second guide wire between the balloon and the lesion, and this guide wire is then rapidly withdrawn, producing a cutting effect and hopefully modifying the lesion. Another commonly used technique is the anchoring balloon support, which offers additional support by inflating a balloon in the proximal side branch to enhance the guide catheter stability and alignment. Appropriate sizing of the anchoring balloon is crucial to prevent side branch dissection or perforation. Similarly, as shown in the right-hand diagram, the wire can also be used as an anchor by positioning it in the side branch, which helps to stabilize the guide catheter and offer support. Now, using a lower profile equipment such as 1 to 2 millimeters balloon first can be used to allow a room for larger wire passage. Oscillating the balloon in a forward and backward motion is a technique based upon the physical principle that dynamic friction is less than static friction and can help with crossing resistance lesions. Microcatheters have the ability to transmit torque into and beyond resistance lesions. They can be rotated to minimize friction and facilitate advancement. And in so doing, we can create a small channel, facilitate lumen enlargement through which small and subsequently larger balloons hopefully can be passed. Some examples are shown here. The Corsair, for example, is a type of microcatheter used in PCI, CTO PCI. There is a unique shaft made out of 2 larger stainless steel wires wrapped around 8 smaller wires together with braiding, tungsten braiding, allowing it to be pushed and allowing for better force transmission. The tonus catheter that's shown in the middle panel can be advanced using a counterclockwise rotation and withdrawn using a clockwise rotation. This shaft also consists of 8 individual larger wires stranded together to form a spiral helix, resulting in the tip with higher stiffness and pushability. And some of us may be actually familiar with the turnpike, which also use a unique multi-layer shaft, which is actually used in a clockwise direction to transmit the torque and hopefully cross the lesion. Now, when a balloon fails to cross a lesion, the first step in most cases is to use a small, low-profile but compliant balloon. Now, if the balloon stops advancing, it can be inflated while maintaining forward pressure. This may dilate the entry into the lesion and allow lesion crossing, sometimes even with the same balloon, which is known as the balloon wedge technique. Now, if the balloon fails to advance after inflation, you can simply try the new, smaller balloon. Sometimes operators actually use a technique called the balloon-assisted micro dissection, and this involves actually advancing the balloon tightly against the lesion and internationally rupturing it adjacent to the lesion, which can cause and create micro dissections around or into the lesion. There is a small risk of staining or perforation with this technique, and this is an illustration of this technique, also known as granuloplasty, as shown here, to cross this balloon uncrossable lesion in an RCA. Previously, the lesion could not be crossed despite the Caravel microcatheter and even a 1O balloon. The subsequent clip shows a successful crossing of subsequent equipment and the final result after stenting with a 3.5 and 3.0 DES. Now, high pressure or cutting scoring balloons, as previously mentioned, may have limited usage till the balloons can be delivered. We now have a combination of laser or atherectomy tools available to try to enlarge the lumen. High-speed rotational atherectomy facilitates lesion debulking and crossing where balloons would not track. It does require, however, the thin wire to be passed distally, which on occasion can be challenging, especially in uncrossable lesions, unless primary wiring with a rota wire is performed. We also have orbital atherectomy, as shown, demonstrated earlier, and also coronary laser atherectomy catheters, which are designed to cross, prepare, and treat the most complex lesions as well. This kind of non-mechanical laser atherectomy can be delivered over any wire and can debulk, modify plaques of multiple morphologies. And of course, the role of intravascular imaging. As we all know, plain angiography may not be as sensitive for detection of coronary calcium, while IVUS is sensitive for detection of coronary calcium, but because of the reflection of the sound waves, IVUS may not be able to use to measure the depth of calcium accurately. OCT is more sensitive for detection of coronary calcium, can measure the depth as well as the calcium arc. And this study is highlighted and published in Euro Intervention in 2018 with the calcium score using parameters such as the thickness, the arc, and the length of vessel that's involved. And with the calcium score of, say, for example, that's 4, then there's a greater need for more aggressive lesion preparation and more suggestion of calcium modification required. I'll move on quickly for approach to undilatable lesions. Now, once the lesion has been crossed, it is essential to get adequate lesion preparation prior to stent implantation. Stent deployment prior to effective lesion preparation may end up with underexpanded stent with undesirable clinical consequences. And it is known for some time that luminal dimensions and minimal stent area are important factors in determining a long-term incidence of in-stent stenosis. Therefore, it's important to achieve adequate pre-dilatation before adequate stent expansion can be achieved. And these are two graphs that I got from pretty old papers, illustrating that the probability of restenosis depends on the immediate post-procedural lumen diameter and stent areas. Such that PCI optimization targets actually depends on achieving an adequate expansion ratio of 80% or absolute MSA of either 4.5 or 5.5, depending on which form of intracoronary imaging is being used. Now, in a similar approach to crossing uncrossable lesions, a stepwise approach to lesion modification should be utilized beginning with a least invasive strategy. Non-compliant balloons allow a transmission of high pressure to resistant lesions without a change in volume, thereby forcing the pressure within the lesion rather than transmitting it to other parts of the artery, as can happen with semi-compliant balloons. The shorter NC balloons can help to focus the applied pressure. Now, despite this transmission of high pressure, many lesions fail to dilate and require more aggressive strategies, because sometimes in eccentric calcified plaques, the balloon dilation could be limited as due to the presence of guide wire bias. It may direct transmission of this force away from the calcified segment. We also have the event of the OPN balloon, which is an example of a ultra high pressure balloon, which can deliver pressures up to 40 atmospheres. OPN balloon has a unique twin layer balloon construction, allowing transmission of super high pressures. Balloon can be relatively bulky, such as its usefulness in crossing resistance lesions may be limited at times. Well, this is just one case example to illustrate this LED lesion is calcified, and there is actually a waist with the use of a non-compliant trial balloon, and with the OPM balloon, which should inflate to about 35 atmospheric pressure, you managed to open up the lesion, the waist. All right, so this is the clip showing the vessel after pre-dilatation, and this is the final result after stenting. Now, cutting balloons use multiple blades that anchor the device in the lesion, avoiding a watermelon sealing effect to cut neointimal tissue without balloon slippage. Scoring balloons can be used to minimize barotrauma to the vessel wall and slippage of a conventional balloon when inflated over calcium or fibrotic scar tissue. Now, just going very, very quickly about rotational atherectomy again. So, one unique but rare complication, right, of rotational atherectomy is the possibility of dissection caused by wire bias in the angulated lesion, which can be decreased by bending a guide wire or using a small size initial burr. Imaging can detect the presence of predictive wire bias in atherectomy. Wire bias could possibly have been prevented by the use of, say, for example, a rota extra support instead of a rota floppy wire. Staple wire can sometimes be used to straighten the vessel or lesion to lessen resistance and possibly reduce wire bias. Some may recommend the adoption of a relatively more conservative rotational atherectomy approach, whereby the burr to artery ratio is less than 0.7, followed by routine balloon angioplasty. And the new approach involves the use of a lithotripsy balloon, which emits multiple shockwave pulses to fracture the calcium. So this is done by performing a low pressure balloon inflation to oppose the IVL balloon to the vessel surface and position the device. The generator is outside the patient's body. Actually introduce an electric charge to produce these ultrasonic shock waves that's transmitted through the balloon to modify the calcium and introduce microfractures in the vessel wall. Now, the primary IVL therapy for patients have been indicated for patients with calcified de novo lesions, secondary therapy for patients with calcified lesions in which, say, for example, non-compliant balloon dilatation has failed, and lastly, potentially for patients with stent under expansion after previous stenting. This is one of my last case example. So this is a long, diffuse, tortuous calcified lesion in LED as shown in this LAO and RAO cranial views. So LED wiring was done using a hydrophilic wire on microcatheter support. Primary rota strategy was done using a small size burr at 150,000 rounds per minute. And followed by a routine balloon angioplasty using a plethora of cutting scoring balloons as shown here. There was still some waste after the cutting scoring balloons. We elected to use intravascular electrotripsy, as shown here, and then even with the OPN. And this is just an example of the final result after stenting. Intravascular imaging showed reasonable results as well. So this is my take-home message. So essentially, I think one of the strategies to approach uncrossable lesions would be to increase the forward force, all right? And one way is to increase support by either using the appropriate guide size, catheter size and shape, and with the use of the guide catheter expansion if appropriate. Wire support strategies such as body support or wire cutting techniques, anchoring balloon techniques, for example. Another method could be use a lower profile equipment using semi-compliant balloons, the smallest one possible, 10 M, for example. Wedge balloon techniques or balloon assisted microdissection, and the use of a microcatheter that's talkable and can transmit the torque would be useful here as well. And to the other strategy is to enlarge lumen, which is also used to especially dilate the undilatable lesions. And this could be done using a combination of atherectomy based or laser techniques or balloon-based techniques as shown here. And of course, central to the role of this algorithm, as highlighted earlier on, the use of intravascular imaging can actually help us to decide which one to be used. For example, if there's an eccentric low calcium, then one may elect to use balloon-based techniques such as NC balloons, high pressure balloons, scouring balloons, cutting balloons. And if, for example, there is a concentric high calcium or the calcium nodules present, then potentially IVL or even a rotational atherectomy may be indicated. And with that, thank you very much. I'll stop share here and then invite for comments.
Yep, thanks, Zhen-Vin. That was a very comprehensive talk. Saw Sydney had his hand up, so maybe just one comment or one question. We'll let Sydney have the floor.
Sure. Thanks very much. Look, excellent talk. I was going to say that with the laser from Colombo and from an Australian centre, you have to put a laser in that undilatable area and then inject contrast rather than saline, heat up the artery and then dilate it with an NC balloon. But I saw a recent case report about a undilatable lesion, which they modified with a CTO technique after stenting, is that they've gone outside the stent because they've tried everything else. IVL as well also failed, including imaging. And they had actually basically went outside the stent and modified by dissecting it around it and then re-expanding it. So I thought that was quite clever, but also high risk.
That's very thinking out of the box. Okay, Dr. Lucio, would you like to introduce the next speaker? Thanks.
Yes, Dr. Alan Chan, who is currently the catheterization laboratory director in Department of Queen Elizabeth Hospital in Hong Kong. And nowadays he's special interest in CHEE and CTO intervention and promoting the primary PCO program, Stent Life. He's now going to give us a very nice topic about orbital shock in CHEE. So Dr. Chan, thank you very much. And we are listening to you.
Hello, can you all hear me?
Perfect, Alan.
Okay. My computer needs to take some time to share my screen. It's okay. Thank you very much for inviting me again to this very comprehensive and exciting imaging symposium. So as mentioned, I think the last few speakers have talked about the various strategy in tackling calcium. So in fact, my talk is trying to illustrate one fairly challenging case in a CHIPS candidate by using a combination approach of both orbital and shockwave. So my comment, yes, okay. So I go straight to the history. So my case, my patient is 82 years old gentleman. It's very old age. He had got multiple comorbidities, including diabetes, hypertension, hyperlipidemia, COPD, history of subdural hemorrhage, actually also with atrial fibrillations, but refused anticoagulations. This time he was first presented with a non-STEMI in another hospital. He also got CKD with creatinine clearance only around 30. By the same time, he was also newly diagnosed to have a severe aortic stenosis with preserved ejection fractions. Core angiogram from the Bristol hospital showed a triple vessel disease together with left main bifurcation lesions. And in fact, from the angiogram, we were able to show you in the next slide. This is a diffuse calcifications. So the patient was discussed in a heart team meeting, but because all you understand is the really high surgical risk candidate because of the comorbidity. So it was consensus to have a high-risk PCI followed by Eccentric procedures. So this is a baseline angiogram. From the angiogram, actually you can see the diffuse tremor calcification along the left coronary artery system. There's a lot of left main bifurcation lesions, and this microannulus calcifications together with calcification along the aortas. So the another view actually you can see this is actually the porcine aortas. Again, diffuse calcification apart from the left coronary artery, also the right coronary artery is also diffuse eccentric spiral calcification from the occipital to the also, you can see very calcified aortic swell. So it's not really a calcified coronary, it's a so-called pancreatopathy, diffuse severe calcification in a CKD patients. So what is the best strategy? So the heart team decided to have PCI first. So we go to the radial approach. So EF is preserved, however, the patient has EFAS. So we think we may need to have some calcified modification techniques in treating the coronary arteries. So we first bring the patient back for a PCI to the RC first, and this is the saline OCT run. Because of the renal impairment, we decided to use minimum contrast to tackle the right coronary first. So from the OCT, I hope you can appreciate this very diffuse thick calcification. Some segments is concentric 360 degrees, some segments around 180 or up to 220. So in fact, it's very long, thick calcifications. So to make it simple, as mentioned in the last talks, and this very high risk patient, of course, options will be we did some we need a moderate support in order to have a safe procedure, but cost is always a concern. So for this particular case, the OCT can pass the lesion. So we think that we may use an upfront ballooning-based strategy, including the IVL. But however, when you use a 3O shockwave balloon, this is the image we can able to obtain. You can see despite the multiple therapy from the 3O balloon, actually the shockwave balloon didn't really get yield lesions. And this is the OCT, again, say like the derived OCT. And you can see it's only induced some minimal or minor calcium fracture at some of the tips. The thick calcium, they have nothing new. You can see the same, a little bit juncture of calcium fracture, but I don't think it's a good lesion modifications. So next step is try to use atherectomy. So of course, this is the issue of discussion whether to use rotational atherectomy or optimal atherectomy. In this particular case, we opt to use optimal atherectomy by several reasons. First of all, it was told that optimal atherectomy tends to have less so-called low flow as compared to rotational atherectomy. And in this particular case, it will be particularly relevant in the CHIPS candidates for severe aortic stenosis. So we use orbitals, low speed, and then high speed because we all understand this is a big vessels. Distal 3.0, mid 3.5, and portal 4.0. So probably we may need to gain a lot more luminal gain before we can open the yield lesions. Of course, as mentioned in the previous talks, it may be a good practice to assess the results after the atherectomy, after the lesion calcium modification technique to see do we need anything further to further modify or to prepare the lesion before we understand and do the stentings. So in fact, you can see actually we can able to achieve some stentings or achieve good luminal gain, but you can see still there is a lot of heavy concentric calcification at certain junctures within the RCA. In particular, probably around here, you can see the cracking. But however, cracking here, but still very thick calcification. So we are facing so-called the super calcified lesions. Of course, the next step probably you may use NC balloon, scoring balloon, or PM balloon. But in this particular case, actually, we have experience using combination approach. Actually, day back to 2019. For example, Lampo, we talk about rotor shock, and this is one of the cases we described in the literature of using orbital trips or orbital shock. Next step, we use the shockwave balloon again, and this time you can see we can able to yield the lesions beautifully from the angiogram. And then after the 3.0 shockwave, we use 3.5 to modify the proximal right as well. Again, it's time to see is this adequate? So again, the saline run of the OCT, you can see these apart from the original orbital standings, in the concentric part, you can see beautifully there is orbital calcium fracture, particularly over the circumferential calcium regions. So I think it's the right time we can proceed to further ballooning by means of high pressure balloon and then standings. So this is the NC balloon. You can see beautifully get dilated, and you get the 235 stand from the mid distal all the way to the ostium. After standing, further post-dilatation, and this is the final OCT run. You can see this is still a saline run, but you get good image because of the RCA. Whereas if next step when we go to the left side, probably OCT, saline OCT will not be a good option. You can see because of the very fragmented fracturing of the calcium, so-called, to my description, it's just like you crack the biscuits, you still have lots of calcium behind. So the stenting afterwards always looks a little bit interesting. I think if we have handling more of these calcium fraction, very deep calcium all the way to the meningia. So as you stand, especially is pretty good. So in the coming few slides, just a quick snap of the stage PCI to the left. So in fact, a saline OCT may not be a good choice in these big territories. So this is one of the first tools. Of course, we are using ultra low dose contrast in order to facilitate the success the complete PCIs in the CKD patients. Again, we try to use the IVUS but fail to cross, so we are only able to image some of the lesions about in the left main. And again, we try to use Shockwave in order to avoid atherectomy at the very early beginning because of the CVAS. So, but you can see there's some yielding in the proximal LED, also left main, but however, we still can't cross the lesions in the proximal mid LED. So we take out the orbital again. This is the IVUS. When we pull back all the way, you can see the very concentric calcium and thick, and then the critical tight lesion despite the initial Shockwave above. So we use the orbital to treat the proximal to mid segments in order to modify the uncrossable lesions in this particular case. And we again try to avoid rotational atherectomy in this particular case because of CVAS. So we treat all the ways. You can see how tortuous is the vessels, of spiral classification. So probably orbital also will give us extra sendings because we can use low speed together with high speed. And final touch, where we come back to treat the left main, we use the orbital by means of pull back techniques in order to treat the left main classification as well. So I didn't bore you the details. I have so good result, and then this is the result after we treat the left main publication by using the publication standing techniques. And in this particular case, I think the original is the Coulomb standings. So last but not least, we bring back the patient for a target transfemoral approach, but you can see this patient actually got very calcified femoral disease. This is the peripheral IVUS from the volcano. It didn't really pull out the image, but I believe me is fairly calcified and concentric learning. We use the peripheral shockwave balloon to open up the iliac artery before we can pull out the TAVI. This is the Sabian 1E sheath, and direct them with a Sabian S3, and then this is the and then we can achieve the satisfactory target result. So last but not least, this is the final angiogram. You can see some dissection tracking, but in peripheral vessel, in case you get good flow, totally is good enough. You can leave it alone. So the patient remains stable 2 years after all the procedure and maintain on aspirin after complete cause of death. So I didn't really show you the patient actually also get a LAAO procedure. I think if you go back to this image, this is the LAAO device. So follow-up echo shows satisfactory EF again with satisfactory TAVI functions, the device functions. So ladies and gentlemen, in conclude, I think we are facing more severe calcification in our patient, particularly elderly patient with multiple comorbidities. Imaging, as mentioned highlight in this symposium, is a key in assessing the degree of calcification as well as to guide our treatment strategies. Orbital atherectomy may have a lower risk of slow flow as compared to rotational atherectomy, which may be important in CHIPS candidates. Combination approaches are increasingly used nowadays to achieve the best clinical outcomes. So the calcium modification techniques like Shockwave, apart from treating the coronary, don't forget it can also be used from the peripheral versions to treat the peripheral vessels to facilitate large bore vascular access procedure like TAVI or impeller insertions. So thank you very much.
Thank you very much, Alan. Very nice, your lecture. I want to ask you something. Do you used to use after you can't cross with the IVL orbital, or you prefer perhaps in some times of like this, like in LED case, to use a rotablator and after shockwave or non-compliant balloon or whatever?
So my usual approach, I think, also the calcification treatment algorithm, which has been shown before, and also there's multiple versions of them. I think the key is usually first try to use imaging to assess the calcium first, because I think it will try to give you more options. For example, if you use the balloon-based strategy, using the balloon to palpate, so-called the palpation is also a strategy, particularly more commonly used in Europe. So in case you have some very big dissections, fractures, but you can not yet able to yield the lesions, you may limit your options. For example, orbital atherectomy may not be really good choice, because a big dissection may prevent or have a high risk of using orbital atherectomies. Probably the only option at that juncture maybe you use rotational atherectomies. So in case we are facing calcium, I think we still recommend to use upfront imaging first. And in case the imaging really can't cross lesion, I think this already give you hints for you to use upfront atherectomy device. And very likely, probably you may use either rotational or orbital, depends on your preference and the availability as well as the lesion characteristics.
Nice. Do you think after IVUS assessment or OCT assessment that you choose no IVL, you choose orbital? Do you think the possibility of dissection will be greater with orbital than rota, or what do you think about that?
It's really a good question. So again, it really depends on the anatomy. So it is said that the orbital actually may be better for eccentric calcifications, but you need the operator need to be very cautious as well for eccentric calcifications. That means it's not a concentric 360 degree. You still have fibrous tissues in certain parts of the vessels. So for the standings, you need to be taking extra cautions. Don't stay at certain segments or regions for a long time. Otherwise, as mentioned by Tom before, actually it had high risk of inducing very destructive dissections, intimal disruptions in those fibrous flux. I think you need to pay extra cautions, particularly in those really eccentric lesions. We have experienced some cases which have been staining, weakening of the vessel because of the, especially for very eccentric calcifications. But for concentric calcification, I think the lesions actually, the calcified ring actually protect you. You just can make a big sentence.
Do you have experience, the last one, you have experience doing after orbital or rota doing IVL? When?
Sorry.
After doing plaque modification with orbital or rotablator, do you used to use IVL, or you are continue with no compliant balloon and then stenting?
Oh yes, as I think as mentioned in my talk, I think the imaging information obtained from the post-atherectomy imaging techniques, probably OCT in case we can, will give you whether we can proceed to routine high pressure balloon or IVL. So I think we go back to the same algorithm, the OCT scoring. After we so-called debulking of the really extremely thick calcification, the remaining calcium thickness will give you the insight whether we still need use IVL or not. So I think this is, we are returning back the algorithm again to see what is the next step. I think this is particularly useful for the extreme thick calcification. So it's not the usual thickness calcification that we just use exercise the algorithm. We need to do the tries.
Thank you very much and congratulations.
Okay, so thanks, Alan. Next up, we have Dr. Ho Lam, who really has been the anchor person behind all our meetings. He'll be presenting a rotor shock case in a chip patient.
Okay, thank you, Dr. Lee. I think my case will not as complex as Dr. Alan Chan. Compared to his case, this patient was 40 years old lady. She got multiple medical problems. Actually, the major problem is she had end-stage renal failure on peritoneal dialysis. I think this is unique in Hong Kong. Maybe not everyone had this experience, peritoneal dialysis. She was admitted for ACS APO with VF arrest in 2018, and we had done PCI and patient was well discharged. This was the angiogram of the patient in 2018 while she was admitted. You see there's vital facts, critical SERT and post-mortality as some lesion, some calcification. We had done the PCI and patient was well and was discharged. So what will happen after 3 years peritoneal dialysis? This was the angiogram of the patients after 3 years. The PCI was done actually very good, but even everything was good, but after 3 years, you can see, I think this is quite common. Actually, MACE rate is around 40% for all those end-stage renal failure case. You can see that there's a subtotal critical lesion at osteocert, some lesion at the proximal AD, and there's a mid-AD CTO. The vessel was heavily calcified. I would like to talk about something that is really real life. And like Dr. Lucio mentioned, not every patient has IVUS OCT intravascular imaging. Although this is an intravascular imaging webinar, but I would like to say in some situations you really can't use intravascular imaging. Like this case, microcatheter cannot pass, IVUS cannot cause as well. We have to open it with a small 1/0 balloon and then change with the water wire and then do the water ablation. This was the angiogram after the water ablation. We had not done PIVUS. So if you can do, that is good. But if you can't do, sometimes you have to face this situation, and it's also okay, because once you know that your imaging catheter cannot pass or it's difficult to pass, then you have to step up your strategy. You need some atherectomy, particularly water ablation, because it helps you to smoothen the vessel, and then so that you can pass the device more easily. So this is the angiogram after water ablation. Many of the time, we will end up a situation like this. So my talk is about water short. So why we have to use water and then we use shockwave also. So this is one situation like this. Here the AD is CTO, and there's a bifurcation lesion. The osteo lesion was heavily calcified. The diagonal, osteo diagonal was heavily calcified. So if I want to treat this diagonal, I have to do water ablation on the diagonal, and then I have to remove the AD wire. So in usual situation, if it's not CTO, it's okay, you can remove. However, if it's in this situation, like this case, if it's CTO, and then I remove the wire, I wire the diagonal, I do the water ablation, but maybe 5% chance I cannot rewire the AD, and then the whole procedure will look very stupid. So this is the first advantage of water and shockwave together is you can keep the main branch and the side branch all together at the same time. And then in this situation, I just keep the main branch wire and then wire the side branch and then do the shockwave. And then afterward, I can do the stenting. So I would like to talk about the second advantage of using water short. That is the further improvement of the water result. And before I talk about this, I would like to maybe we can just share my experience. So in CTO, most of the time you use IVUS. So can IVUS predict successfulness of your water ablation? This is really controversial. There's no definite answer for that. I think how to use the intravascular imaging to predict your water patient successful or not mainly depends on comparison of your P-IVUS and the IVUS after your water patient. So like this situation, if you don't have P-IVUS, probably IVUS is not feasible imaging tools for you to predict. So in this situation, I just skip the use of intravascular imaging. Maybe the best way is use a balloon. I use an NC balloon, a few NC, and then in phase, you can see the behavior of the NC balloon, and probably this is the most accurate. Actually, it's accurate, more accurate than intravascular imaging about prediction of successfulness of water patient. And then I think the concept nowadays had changed. Also, it is also my experience. We found that if we just do water patient, the outcome is not good enough. Many of the time you need to do something after water patient. Maybe just water afterward, you have to do high pressure ballooning or cutting balloon or using scoring balloon or OPN or shockwave or CSI or whatever. Many of the time, nowadays we found that just water is not enough. Water plus something behind that is better. So about using water and shockwave, we know that using the shockwave, further use the shockwave may improve the outcome of the water. However, I will not recommend routine use of shockwave after the water. The reason is because first it's expensive. The second is you will have some improvement, but not always. I think for major improvement is around only 10%, but maybe some invisible improvement that is very common because recently some case study, some paper published after the shockwave, although no visible improvement, but there will be some microfracture over the calcium. So whether this can lead to improvement in clinical outcome or not, this is still need more data. I cannot say. But anyway, in this case, we can find that after water patient, we use NC and try and see. Seems the opening is not very good. So in this case, and money is not a concern, we will use shockwave. And for the shockwave usage, there are many ideas, for example, guide by OCT, guide by IC. For this sort of situation, I will recommend the best way is guide by stent boost. Actually, you can try. If you put the shockwave in and then you do the stent boost, you can see the calcium clearly over the vessel. And then you found the most calcified lesion, and then this is the page for you to deliver your shot. And then after that, we put the stent. You see it's open well. So we can see the result after the water and then shockwave for this calcified lesion. And we see the IVUS was fully expanded circular very well. So so you can see that may not be necessary for the IVUS. I don't use IVUS, but you can also have a very smooth procedure. However, why you still have to use the IVUS is because for those calcified lesions, it's very difficult to see the apposition of the cell stent structure. For example, like this case, you see the angiogram. Can you be sure where is the apposition? Where had the apposition problem? Which part? So for the IVUS, you can see, or OCT, you can see very clearly about where we'll have the apposition problem. For example, like here. So this is actually quite common for calcified lesion. Many of the time after all the ballooning, you will have some apposition problem. You can assess and see if you have to fix it. So the second thing is, now, although I think probably you need more technique or experience to use IVUS to predict the successfulness of a water patient or not, but IVUS is a very good tool to predict the need of water or shockwave in general. So, for example, like this case, this situation, now the vessel was heavily calcified. For this lesion, do you need shockwave? Do you need big water to open it? There's some haziness. It could be just some haziness, or it could be a heavy calcium. So IVUS in this situation can help. So we can see the circumferential calcium. Okay, this is the scatter calcium mentioned by Dr. Chin before. So you can see that for this scatter calcium, actually is the pace of those haziness. So you see the haziness. We had checked IVUS. Here is just show some scatter calcium. For this sort of lesion, it can be opened by NC balloon. So we just use NC open and then stand. So the major challenge of this case is to use supercourse to wire this super vitrovascular subtotal lesion, and then we finish the case. So with some stand, this was the final result. So in summary, we had demonstrated two advantages of water short. One is to keep both main branch and side branch wire, and you can short the side branch. The second thing is water combined shockwave can improve, further improve the outcome of your PCI in calcified lesion. Okay, that are my sharing.
Well, thank you very much, Lam. That was definitely a great case. So does anybody have any comments to make?
Yes, Shan. This is a very nice case, Lamku. You have a very calcified plaque with a CTO in LAD, bifurcation, LAD diagonal. First of all, you use EVL for diagonal branch, and then you use ROTA and non-compliant balloon for LAD. The question is, you guided all these procedures by IVUS, and it was great, and congratulations. But if you don't have any economic issue, do you use, instead of non-compliant balloon, IVL, or after non-compliant balloon, IVL, or you will just stay with the result like this?
Yeah, I think the current concept in motivation has changed a bit. You just not to do the water, not just do the motivation. You need to do the motivation, and then afterward you need to do something, either cut or NC or OPN or shockwave. So if money is not a concern, then I will routinely use shockwave because it's safe and anyway, it's ultimate. If the pressure is equal to around 50 if compared to NC. I find it is even more safe than OPN, because with OPN, balloon fusion is quite common. I had used OPN a lot before. I found that if I inflate the pressure up to 40, many of the time balloon fusion will occur. So if money is not a concern, then just very simple, safe, easy. I just put a short wave and then short, and most of the time it's okay.
We need a longer balloon for shockwave.
Yes. The deliverability is a problem. So many of the time after motivation, you can pass the shockwave down.
So Alan, I see you've got a comment to make as well.
Yes. Thank you, Lam host, for the very really educational talk. So I think the highlight today, apart from imaging, which can guide our interventions, the another important essence is how can we tackle calcium lesions safely. So I think we all experienced in the past that we are very excited after the atherectomy, after, for example, rotational or orbital atherectomy. But once we pull out the balloon, we did have occasional case that result in nasty perforations. I think it's particularly in the eccentric classification we are talking about, because the fibrous plug opposite to the calcified lesion just yield very effectively and then rupture. So I think the dilemma nowadays, despite we all get very useful gears in our lab, in the combinations approach even, we are still facing a certain minority proportion of patients will still result in nasty complications. I think at the end of the day, imaging is the only tools that can help able to tell or try to predict, but in particularly which patient will result in those nasty complications. Particularly, I think the still nightmare will be the eccentric classifications, like the first case for osteo, where is calcified nodules. I think the calcified nodule can most of the time never yield. The very excellent case in the first topic presentation. I think in the unlucky days, probably the vessel will get rupture and then result in getting very difficult situations.
Sure. So thanks for the great comments, Alan. So I think in the interest of time, probably Chee Young, we can move on.
Yeah, thanks. So the next speaker will be Dr. Jonathan Song, also from Hong Kong, and he will speak to us about how to deal with calcified osteal lesions. Thanks, Jonathan.
Hello, everyone. Do you hear me well? Hi. So,
yes.
Hi, everyone. It's a pleasure to speak to you today about management of coronary calcium. I'm Jonathan from Hong Kong. And following a remarkably impressive case of orbital tripsy presented by Alan, I felt like there's very little I could add on. So my only task right now is to make sure my case will not bore my audience to sleep. So I have no disclosures to make. So to begin with, we had an 85-year-old lady with a history of hypertension, atrial fibrillation, who had an episode of acute coronary syndrome while she was admitted for severe pneumonia. So after the pneumonia was solved, we brought her to the lab. Before she came, the echo showed a good LV function with no regional wall abnormality. This is the left side. You can see the mid to distal LAD was pretty nasty, but wait till you look at the right side. So you can see there is a pretty tight RC ostium here, and as we engage with a diagnostic catheter, there's severe pressure damping. So you see this image was taken with the catheter hanging outside. So we decided to move forward with intervention in the RCA. We established a 6-French right radial axis, use JR4 6-French guide catheter. Usually for RCA, I like to use a little more aggressive guide, such as an AL. But for this case, because the ostium is very tight, we use the JR4 and to keep it hanging outside the ostium, and we use a workhorse wire to enter the ostium by fishing it. And then we quickly did an IVUS. This is the picture of just the ostium to show you how tight it was and how calcified it is. Still image here. So we decided to start preparing the lesion. We wanted to test how tough this lesion is by just performing an NC balloon angioplasty first. We use a 3/5/20 NC balloon, and by just looking at the angiogram here, you can see the balloon is not actually expanding at all at the point of the ostium. And so we decided to do orbital atherectomy. Well, the reason why we chose orbital over rotational atherectomy here is because the location of lesion with orbital, we can perform atherectomy even in a backward motion, but with rota, it becomes very difficult, especially without a good guide support. So here you can see we put in a backup pacing. It's not mandatory, but we have time, and we decided to just keep everything safe. And we performed 11 runs in total, 7 runs on a low speed, followed by 4 runs on a high speed, given the caliber of the vessel. And we moved very slowly at the ostium to make sure it worked effectively and safely. And then we try to see what we have achieved with another NC balloon angioplasty. You can see the balloon is not exactly expanding fully, but it's marginally better. We repeated IVUS because we wanted to present this case here. And you can see, well, the lumen, there's a little bit of luminal gain, but it's still not optimal. And we do not want to put in a stent at this moment because we know there's a risk under expansion. And after putting a stent there, our hands, we don't have much options left. So we decided to do Intraphysical Electrotripsy. So we used a 3512 Shockwave balloon. We used all 8 cycles of therapy at the ostium, inflating the balloon at 4 to 6 atmosphere. And with each cycle of therapy, we noticed that there is gradually improvement in the expansion of the balloon. And then we wanted to test how much we've achieved by performing NC balloon angioplasty again. It is my own habit that I like to follow up an NC balloon angioplasty after each time I use an intravascular electrotripsy, because after cracking the calcium, I wanted to see how expandable the lesions become, and also the NC balloon will help to open up the lumen. And you can see now, just by the angiogram, there's markedly improved expansion at the ostium. And now we repeated the IVUS. The lumen is actually much bigger than before. And you notice there's a good cracking of the calcium. And now we perform stenting, and by putting a 4.0 33 drug loading stent, and then we optimize the stent with 4.0 and 4.5 NC balloon. And look at the 4.5 NC balloon. You'd probably notice when after we deployed the stent expansion was still not optimal, but with the NC balloon for stent optimization, it's actually much better. And this is the final IVUS. The stent expansion is actually not bad, given how hard and how small the lesion was to begin with. And here's the final angiogram. The left side was relatively more straightforward. We put in 3 overlapping drug loading stents. So in conclusion, here we have the balloon on dilatable calcified ostial lesion. Our strategy here is to first use an orbital atherectomy to debulk the calcium, especially since given the ostial position of the lesion, the orbital atherectomy allows us to debulk the calcium with a backward motion of the atherectomy device. And after debulking the calcium, it facilitates further cracking of the calcium ring with intravascular electrotripsy. And we follow up by a non-compliant balloon angioplasty to open up the lumen. And before we really put in a stent there, we want to confirm the dilatability of the lesion, because after putting a stent there, our options become very limited. And as we've illustrated with all the presentations today, intravascular imaging in the management of coronary calcium is essential. So here's the end of my presentation, and welcome any questions from the floor and the panel.
Thanks. That was a very good case, actually, Jonathan, and thanks for keeping it nice and concise. Maybe we spend a couple of minutes. Maybe you, if you don't mind, explaining again to people who maybe don't have much experience with CSI, with the orbital atherectomy system. Why do you say that how is it that OAS can affect the calcium both moving forwards and backwards, whereas rota is not able to?
Yeah, so rota, when you do rotation atherectomy, you actually try to debulk the calcium as you move forward, but it's fine for all lesions of in other anatomical positions, but for the ostium and with very little guide support here, the rotation atherectomy would not be as effective. With the orbital atherectomy, it works in both antegrade and retrograde motion, so it gives you further advantage in these osteal lesions.
And I think Dr. Chui had a question in the chat box. So your technique in this case, was it to advance the orbital crown into the vessel and then ablate pulling back, or did you ablate going forward and backwards?
I do it in both forward and backward.
Okay. Dr. Lucio, you have your hand up. You want to ask a question?
Yes, Jonathan, congratulations for your case. Do you ever do in this osteocalcified lesion, first of all, always orbital, or do you prefer just because of this result doing no compliant balloon first, and then if IVUS says you have a 360 concentric calcified plug, to do IVL from the beginning? And the second question is, after IVL, do you use no compliant balloon, or you just put a stent after IVL?
Thanks very much, Dr. Lucio. So for the first question, I like to test the calcium by performing balloon angioplasty first. I like to know, I think even with very good imaging, I think it's very difficult to predict the behavior of your angioplasty in a calcified lesion. So I like to test it with a balloon angioplasty first. Of course, the flip side of that would be you might cause serious dissection in the vessel, and then you lose the option of orbital atherectomy. But still, I think I want to know, to understand more about the nature of the lesion. I think doing a balloon angioplasty upfront, especially with an NC balloon, would give me an educated guess on how to approach this lesion. And of course, doing imaging would help, especially with an OCT, would give you a very optimal image of the calcium. But since this is an osteal lesion, we're not confident that the OCT would give us what we want. So we had to resort to IVUS. But still with IVUS, we can see that there's a 360-degree calcium ring with fairly thick calcium. Then we know Intraphysical Electrotripsy alone might not be enough, because if the calcium is too thick, then it doesn't really crack it that effectively. So debulking it first with some sort of atherectomy and then following up with IVL would be good. And for the second question, as I mentioned, once you put in the stent there, your options become very limited. So I like to make sure that the lesion is truly dilatable before I put a stent in. So I would always do a balloon angioplasty after all the maneuvers. And secondly, the NC balloon does provide us more luminal gain after the intraphysical electrotripsy. After because the shockwave only cracks the calcium, it doesn't really open up that lesion that much. But the NC balloon after the IVL would open up the lesion for us.
This is a very educational point of view to say that after IVL, we need to do no compliant balloon inflation in previous stenting. Thank you very much.
Thank you.
Vincenzo, a quick one before we move on.
Yes, a very quick comment on this last sentence from Jonathan. And I think he's completely right. I mean, at the moment, we don't have a real imaging tool to say, okay, the modification of the calcium that we have achieved is going to make a perfectly expanded stent. Yes, we can see cracks, we can see the modification done by rotational atherectomy of the orbital, but we don't have a clear, definite cutoff to say, okay, the stent is going to expand for sure. That's the reason why I too do always an NC dilatation after any modifying tool technique that I use.
Thank you.
Okay, great. Moving on now, we've heard a lot from him already, Dr. Lucio Padilla. He is from Argentina. He is widely experienced interests in many aspects of interventional cardiology, including CTO. So he's going to give us a talk about a complicated shockwave case. Please, Lucio, thank you.
Thank you very much. I'm going to present a case of a male with prior acute MI with stent in LAD in 218. And in 219, previous the COVID era, he had a PCI to circ with a stent in the proximal and in the mid circ. And in 2020, he have an stent restenosis in the distal circ stent, and they put another stent. So nowadays, he actually is with angina with severe lateral ischemia. So he had in the coronary angiogram that we always try to show this. It's very important to have not only the angio assessment, but try to do an imaging to know in all the restenosis what is going here. So here, this patient have a stent in the proximal. Here, we have two stents, and we have another restenosis. So as you see here in the circle, we have two files of stent in this and diffuse restenosis here, and something in the ostial and something here, but this is the point of this focal stent circumflex restenosis. So this is the IVUS, and what I show is this. This is in the two stents files in the distal or mid circumflex. We show this 360 by IVUS shows this this instant restenosis. Then we have between the proximal stent and this stent, this plaque, this is a soft plaque, but it's a severe one. And here we have in the ostial, previous to the stent, another severe plaque. So some disease here in the proximal LAD too. So the idea is what to do to this patient. Two stents here, another is a very young people. So I used to do not only angio and not only IVUS, but always I do stent boost technique. So I try to do a plaque preparation in the instant. Here is the point of the instant, looking by iLab. And here are the stent boosts in the point of the instant restenosis with double stent. So these are very nice images to know what to do. So this is the previous images that show a restenosis, the in-segment restenosis, previous these stents and between the two stents. And so in conclusion, we have a focal stent restenosis in mid-circumflex, infra-expanded stent, superficial and deep calcified plaque, severe interstent lesion in mid-circumflex, and severe ostial circumflex lesion without stent. So trying to go with this, we have a 300 concentric calcified plaque with under-expanded stent. So more than 180 degrees, I think it's more than 0.5 millimeters and more than 5 millimeters. So what is the technique to modify the plaque? Here it says we are going to do Shockwave. And so my strategy in this case is no compliant balloon, first of all, then IVL, if not rotablator, and if I do rotablator, always guided by IVUS. What about IVUS, IVL post-rota? I don't know, this is, and then DEB in the distal circ, and DES in the ostial mid circumflex. Then we can discuss this, but this is my strategy. So this is IVL 3.512 in the stand, and this is the stent boost after the IVL 8 series. So this real life is the angio. So what about this? I couldn't modify the plaque, I couldn't modify the stent. So do I have to do rotablator? What about this? So I changed to a H-French guiding catheter. Look at this, a bar 2.0. Look that I was ablating, and here a systolia because of the ablation, but nothing here. Then I do another ablation with a 2.0 bar, all okay. And this is the stent boost. What about after the rotablator? It seems to be better, but it's not completely okay. And this is after a no compliant balloon after rotablator. This is the stent boost. So this is this tool, the stent boost, is a very good option to use in all the angioplasty after stent and after the balloon. So I do, after this, a new IVL 3.512, and this is the result. So IVL, not conclusion, rotablator 2.0, it doesn't a good result, and afterwards another IVL, and this is the result. This is a stent boost result, and so we have a modified plaque. And then what about this? I do a DEB in the distal circ in stent, but what about the parts of the stent where we have done rotablator? Can we leave this with DEB, or can we need to put another stent and to cover the ostial lesion and the interstent lesion? So I did that. I don't know if it's okay or not. This is the result with some plaque in the LAD. So I do IVUS. It was severe. I put from left main to LAD. And this is the result, the final result. These are the stents. These are the instant in the mid, between the stent and in the ostial. So this is my final result. I want to share this with you. So I want to discuss with you a lot of things. No? First of all, how to assess. The angio is not easy to be a conclusion, and then to say what to do in this type of two restenosis, two stents, focal in-stent restenosis in the circ, in a young people, what to do.
Thanks, Lucio, for that. Anyone want to comment?
Yeah, can I make some comment?
Yes.
Yeah, besides what is the best strategy, it also depends on the level of your experience. If you are not good enough, it's very difficult to use 2.0 burr in this sort of ISL case, non-dilatable ISL, because trap burr is quite common. So I will recommend, if you're at beginner level, maybe just try double shockwave. I had tried double shockwave in one case, and one shockwave is not open, but two shockwave is open. So, but the trick is after one shockwave, you have to use NC balloon to do a high pressure, so that all the calcium pack again, and then you do the shockwave again. So of course, if you have good technique, then the two-wafer, and then shockwave may be the best way.
But Ho Lam, after the first IVL, I used 3.5 balloon, no compliant, 26 atmosphere, nothing. So I go with rota to break and to break all the stents, the previous stents, and after that to prepare again the plaque, because I couldn't go until to the calcified superficial and deep plaque. So what about, do you have experience doing rota after IVL because it doesn't work? And then I saw that after rota and no compliant balloon after rota, the stent wasn't very nice too. So I do again IVL, and then I have a good result after no compliant balloon 4.0.
Okay, Vincenzo, you want to say something?
Yeah, Lucio, if I understood well, so the point where initially the IVL didn't work was in a place where there was multiple layers of stent, right?
Two.
Okay,
Two
so
sets.
yeah, so I mentioned during my presentation that a group of European and actually international colleagues have published the CRUNCH study, which was a registry showing the effectiveness of IVL to treat under expansion of stents. Well, they had the lovely results, except when there was more than one layer of stent. So this outcome of yours has been confirmed in other cases.
That's why I present this. So
Alan?
I think that in some situations that with one layer of stent, IVL is okay. With two layers of stent, perhaps no, and perhaps you have to modify with rotablator in this type of angio. But that is a daily practice PCI that I need to do. So I want to share this because it's not a common one.
Thanks.
Alan, you have a quick comment or question?
Yes, Lucio. So I think your case again illustrates the limitation of the current product modification techniques. So we need to be open mind that don't stuck in only one single technique, just like in your case. So we will become more frequently encounter those stent unexpansions or just like your case. So really, we may need combination approach. So the stent abrasions by rotational therapy is one point to open the track. Sometimes I think that even the shockwave balloon cannot able to cross those critical tight lesions. So and then even NC balloon cannot give you any way to pass through area. I think and it's beautifully illustrated again using the combination approach, rotor shock, and then try to modify lesion. I think in the past without the shockwave, I think as we discussing in the chat box, I think there's some colleagues mentioned about using the laser. I think probably in US and in rest of the world, shockwave is not available. Probably laser may be the one of the only indication for choosing this ISL case, which underexpand.
I don't have laser. That's a problem. So yeah. I want to ask you, what about to do after IVL with 2 files of stents, rota, and then to correct that with IVL and
can I take this chance to ask a question? I had heard about very special tips and tricks for use of shockwave. That is, if you use pure contrast for the shockwave balloon, pure contrast, not 1:1 contrast, then it will increase the power of shockwave. Is it true? Anyone had this experience? No.
I've heard it. You mix the contrast with saline, right?
Yeah.
So the more proportion of saline, the more powerful your your shocking will be. I've not tried it. No.
No experience. Yeah. Okay. Yes.
I think it's hard to quantify, Lam. I've actually done very dilute contrast, but I don't know if it's working any better or worse.
Okay. Thanks for sharing.
I wouldn't try to risk not to deflate the balloon with 100% contrast. So I wouldn't do that. I wouldn't try that.
Okay, I think we shall move on to the next talk. And Lucio, again, if you don't mind introducing the next speaker. Thank you.
Yes, thank you very much. Dr. Ka-Lung Choo. He's associate consultant at Prince of Wales Hospital in Hong Kong, and he's going to share us a calcium nodule management. So thank you very much to be here with us, and go ahead.
So can you hear me and see my slide? Okay, that's great. So I'm going to share with you actually 4 cases of calcium nodule in different clinical scenario with different clinical treatment strategy. And I will not show you the whole case, but rather I will focus on the OCT images and management of the calcium nodules. So my first case is a 70-year-old male, hypertension, renal cell carcinoma with operation done. And he presented with unstable angina with minimal chest pain on minimal exertion, and also an occasional rest pain. And echo ejection fraction was slightly impaired. And you can see there is some distal left main is a calcium nodule, and there are also severe calcified proximal to mid stenosis. So this is another view showing a eccentric calcified nodule in the distal left main, and also significant proximal to mid LAD calcified lesion. So this is the OCT images. You can see this is a very heavily calcified mid LAD. I will skip some of those. And this is mainly the fibers, but coming in shortly, there's a heavily calcified 270 degrees of calcium in the proximal LAD. And these are the calcium in the proximal LAD. And coming into the left main, and you can see there's a protruding calcium nodule, which is actually in continuation with the calcium plate in the proximal LAD. It's coming in now. So you can see it's a very huge calcified nodule in the protruding into the left main. So this is still film images. You can see the distal left main MLA is only 5.0. So I did a rotor 175 from left main to mid LAD. And you expect it won't do much on the OCT on this left main calcified nodule. Basically, OCT can predict your rotor result simply by drawing a circle of 1.75 diameters. You will predict how much calcium you're going to ablate, and also from predicting from the wire bias as well. So we use the biggest burr we have at the moment in our lab is a 2.25 burr, and this is an 8 French guiding catheters. We know it's a calcium nodule. We need to ablate it. So this is how we do. After we do the 2.25 burr, you can see the luminal area increased to 6.5. Although there's not much change in the angiogram, but you did actually gain some of the lumen. So we then do some NC ballooning and put into overlapping stent because of the size mismatch. We choose a short stent into the LAD and then a larger stent into the left main. And they both expand very well. And after some post-dilatation, and I do the OCT. So sorry for the poor quality, failed to clear all the contrast. There's some blood inside the lumen, but you can see this is the distal, this is the mid LAD. There's no edge dissection. But I want to go to the left main. So this is the proximal LAD. The left main is coming. And actually, the final lumen gate is quite good. There's some malposition at the proximal edge. So that's why we final touch with an NC balloon. And the final stent area is 10.75, which is good in this case. And we finally touch with an NC balloon to a post stent, and this is the final angiogram. So second case is a STEMI patient doing intraoperatively. So this is a chronic smoker. and history of STEMI 2009 with DES to RCA and then TIA, occluded left carotid artery. And he has newly diagnosed prostate and bladder cancer and admitted for cystoprostatectomy and ideal conduit. But during the procedures, this patient has ST elevation. So luckily, this patient is nearly towards the end of surgery, and patient quickly closed the tummy and then brought the patient to the cath lab. Before they actually do the TEE and found that there is actually extensive hypokinetic wall over the anterior and also the apex. This is the hypokinetic anterior wall, and this is the inferior wall. And this is the posterior wall and also the septum. So this is EKG showing a ST elevation in AVR and V1 and diffuse ST depression consistent with left main STEMI. So we managed to get the access, but it was rather difficult because of the severe PAD. We luckily get in, but probably this patient is not eligible for any support device. This patient is in cardiogenic shock and on very high dose pressure and inotropes. This is the RCA is actually showing mild to moderate disease, and you can see there's a distal left main hazy lesion. So I would say this is a distal left main calcified nodule after the OCT. So I did the OCT, and you can see this is the proximal AD coming in is the calcified nodule here protruding into the left main with some thrombus attaching on it. So here is some still film images. I will explain it in more detail. So this is the protruding calcium into the lumen. There's some thrombus on top, and you can see that actually the calcium nodule is rough in surface. Probably its hand is likely to induce some of the thrombosis on top of the calcium nodule. So instead of the smooth contour of the calcium nodule, this is somewhat rough in nature. So because of very unstable and also the thrombus, we cannot perform the rotor ablation or CSI in this case, and also the patient is very unstable. And actually, this case I was done during my year of training, and my attending said there's only 180 degrees of calcium. The other part of the vessel is actually normal or not calcified. So if you put in a stent, even with direct stenting, you are going to expand it, but the final stent area, of course, may not be adequate. So in order to save life, we directly put the stent into left main, and we post dilate with a NC40 and do the OCT. I must say this is not a perfect result, but there's some edge dissection, but there's no hematoma in the distal. And coming to the left main here, you can see there's some eccentric expansion of the stent, and the proximal edge land in the relatively land in the ostium. So we further touch with some NC, and then we quickly close the case, and we plan to bring back the patient later on for a optimization procedures. So if you do not do any ablation or CSI or modification, you will expect that the final stent area may not be as good if you just do the routine ballooning and also stenting. So you will accept this result in the end. So a third case, I want to show this one because it's a complication case. It's a chronic smoker, hypertension, ischemic heart disease with positive EB scan in the anterior wall. And then this is the angiogram. So we think it's a simple case, basically a type A lesion, we will say, and not much calcium on angiogram. So we just do the routine ballooning and then put in a stent, but we found that the stent actually doesn't expand in the proximal segment. We do a 4O NC to post dilate, and this is the OCT. So you can see actually in the proximal AD, there is an eccentric calcium nodule. So that would not you will not know from angiogram alone. So I would recommend if you do OCT or IVUS, you would like to do it like pre and post imaging to maximize its use, because you don't know it is after you stenting, you have no way to modify it. So the operator think that the result is not as good. So this want to show you once more. This is the calcified nodule in the proximal LAD causing, although the stent lumen is acceptable, but the stent expression is not as good. So they just measure the vessel size like 4.5, and then they use a 4.5 NC to blow it up to very high pressure, and then cause that severe S type 3 of kind of perforation. And they try to put the cover stent, but actually cannot seal because the perforation site is very close to the ostium. And there's some spasm. We have to ask the surgeon to go in, and unfortunately, this patient didn't survive after the surgery. So this is the quick last case. It's osteo RCA in-stent restenosis with a calcium nodule. It's a 78 years old hypertension DM, ischemic stroke, history of PCI to 3 vessels using bare metal stent. Come in this time for end-STEMI GI bleed with tarry stool. And the culprit lesion is in the RCA. You can see it's very calcified. It's a calcified nodule in the stent eye cell. So actually, I use regular workhorse, cannot cross, and not neither the XT series of wire. I have to use a pilot 200 wire to wire the distal, and that's very difficult ballooning, difficult balloon passage because of the calcium nodule. So that's why I use the rotabation to this osteo RCA calcified nodule. So in order to do this, I do by painful during my rotabation, because it's very important to keep your guide coaxial during your rotabation. And also I would recommend you to use the rotor support wire, because if you are not coaxial and you use the rotor floppy wire, you may cut the wire during your rotabation. So you have to check both wheel, the RL and LL, if you have bipainful, and try to keep the wide top on your guiding to make the guide more coaxial during the rotabation. So the difficulty in doing the osteo rotabation is to coaxial your guide, which is usually not the LL wheel, but rather is RL wheel. Some operator may use the LL cranial wheel. So this is the OCT. So this is the OFDI, so you can see it's heavily calcified, but because of the bleeding risk, and there's O stent here, and a heavily calcified plaque, and because of the stent under expansion, this patient has in-stent restenosis. This is the calcified plaque at the ostium. So this is still film. If you use a 175 burr, you are going to make a same 175 burr hole. And so after the warfarin NC balloon predilatation, I put in a stent, and this is the final angiogram. I don't want to extend the stent very long because this patient is having GIP. I want to use a short depth, short stent in the ostium and bring back the patient later on for stent optimization and further stenting in the distal RCA. So just some comments. This is a retrospective study on 400 patients with severe calcified lesion, mean follow-up of 3 years. Calcium nodule is seen in a quarter of cases, and is associated with poor long-term outcomes such as MACE, AMI, target vessel failure, and even mortality. Although this is a retrospective studies, there's signal that calcified nodule is going to give you a worse outcome. So calcified nodule is difficult subset to treat and is associated with worse outcome. And calcium debulking may have a role to improve the final stent area, but there's no data to support this strategy. And also ablation with big burr carries some risk. And heavily calcified west artery, I would choose downside my NC balloon relative to the vessel size, not because we have to respect that this vessel is not going to expand the same one as if the vessel is not calcified. So the expansion limit is somewhat, we have to respect and underside the NC balloon to avoid complication. So thank you, this ends my presentation.
Thank you very much. Very nice case. Okay, what is your summary in order to say what I will assess always with a very good images? You show 2 unprotected left main with nodal case, a calcified plaque, and then another 2 cases, very nice. But after IVUS or OCT, which is the best approach for you? First of all, no compliant balloon, then to do rotablator, or do you think there is a space for AVL?
Yeah, in most cases, I prefer to use OCT instead of IVUS unless the patient has CKD or cannot tolerate contrast because of the poor EF. And I would assess by using OCT to decide which approach I'm going to use. And in calcified nodule, I still prefer to do some of the modification using rotor or CSI. And my personal experience in using IVL in calcified nodule is not that promising, although I saw some of the randomized trials showing that, Disrupt-2 trial showing that actually for eccentric calcium, no calcified nodule, they do similarly compared with concentric calcium. But in my experience, clinical experience, I prefer IVL in concentric calcification, especially if the calcium is thick, more than 500 micrometer. Otherwise, I would prefer to use the NC or even scoring balloon or cutting balloon to save the cost, because IVL is, after all, is very expensive. And the use of actually OCT can help you to make such kind of decision, saving subsequent costs, although OCT also costs some of your money.
Thank you very much. Any other question from the panel? If not, we can continue to the last case, Dr. Sidney Low.
Thank you very much. Look, I am going to be hopefully fairly brief. Thank you very much for the invite, and bring up Beren back end of the meeting. Talking about scoring balloons, and no conflicts. I have to say that I have to look back. These are historical cases. But looking at it, I think the practice has been the scoring balloons has largely been replaced by the use of IVL. This is a case done many years ago, 78-year-old lady with calcified arteries. You can see that calcified circumflex, and there's collaterals to the right coronary artery. And I'm only really going to show these the circumflex artery because rotational atherectomy was performed. Standard 1.75 millimeter burr, reasonable size, intravascular ultrasound. I had trouble finding the intravascular ultrasound, so I won't show that. Flex-tome cutting balloon was done to their segment. And this is a great result. And therefore, actually, after IVUS, we accepted a result. I think the minimal luminal area was around 4.5, 5. And so angiographically, she was fine. And on follow-up for many years, she was fine without any restenosis of this area. So this is a simple rotor and cutting balloon result. A very quick second case. This is a 95-year-old man with calcified disease, LV dysfunction, CKD on apixaban, and this done quite a few years ago as well. Mostly osteo-LAD, but of course plaque extends across the left main. There's some disease of the ostium of the circumflex, not particularly tight in this view. You can see in the RAO view quite a lot of plaque that's calcified the osteo-LAD distal left main region. And there's a burr going down here. I think only 1.5 millimeter burr. So after this, this is the IVUS run. You can see 1.5 millimeter signature, not particularly big in the middle part of the LAD. Might speed up a little bit. And as you can see here, some reverberation artifact, seeing the signature. And the vessel gets a little bit larger as it comes up to the LAD, proximal part, and the left main coming through here. Okay, so essentially after that, cutting balloon was performed, 3.0 in the LAD, prox LAD, and 3.5 cutting balloon in the left main. You can see some of those pictures here, rotor signature, and some cracks were seen. This is a pot post stent. A stent's been placed. It's a 5.0 pot, and that's the result. And that was pretty much all we're going to do in a 95-year-old. And he was all right. This is the post IVUS. And as a case, you can see that we did not do the mid-distal LAD because it means stenting the entire vessel. And there's a part there that's not covered, but with cracks. But as for the stent, you can see the stent coming in there now. Excellent lumen size and area to the ostium of the left main. Okay. So these are kind of the things we're looking at, and quite acceptable results. In terms of modifying things, is the Shockwave balloon also a scoring balloon? Because after all, you're causing cracks. And the open balloon maybe is a very expensive NC balloon with high power. But I'm just going to say that we've seen the cases before today presented, and probably it's not mutually exclusive. It's not one or the other. There are cost implications, but it's a mixture. And I think back in the day, I've seen the Japanese doctors do directional atherectomy, where they remove as much plaque as possible after non-crossing of the IVUS catheter, and no primary cross, rotational atherectomy prior to imaging, and then DCA, and then large stents were able to be implanted. But we're talking about rota or orbital plus IVL, non-compliant balloon dilatation, maximization, optimization, and then a drug-eluting stent and re-image. And in fact, cutting balloon, scoring balloon, various combinations may occur. Of course, I've left out DCA because only Japan has DCA alone. Of course, occasionally, we just take a 2.0 burr and just burr it without actually doing anything else. So the proposed mechanism of action, efficacy, I'm going very brief because I'm not supposed to give much of a talk. If you can see that there are cuts, then must be working. Cracks are kind of what we're looking for. And in fact, they look very similar, right? Cracks between scoring balloons and the Disrupt3 IVL. And so looking back and looking at cutting balloons, they've been around for a long time, but actually the original study here, looking at the mechanisms, really, there's a lot of plaque compression. If you can cut the plaque, you can actually expand it. The vessel compression, vessel expansion was less, but actually the plaque compression was better compared to balloon angioplasty alone. So obviously we can do more vessel expansion too with the scaffolding. And the one thing I would take with the original balloon angioplasty and cutting balloon trial, which is still the largest, simple lesions, but it's about 14% were calcified lesions in this trial. But the coronary perforations, if you size 1.1 to 1, the cutting balloon, there was 0.8% of coronary perforations. And I've experienced that already. In a bench model, the Japanese have looked into this, and they were dilating 3 inflations for 20 seconds or more. And in fact, you can undersize your stent a little bit, undersize your balloon to 0.25 millimeters or 0.5 millimeters less than the vessel size. You notice that the stress, type 1 is where one blade is sitting on the calcified lesion when it's 180 degrees here in this model. And in fact, if you have 2 blades, you need less pressure, and a smaller size may still do the dilatation of the calcium with less chance of perforating. In comparison with NSEs and skull flexes, cutting balloon looks to be, and logically looks better. This is retrospective analysis, but looks like it does more in terms of acute gain and area and stent symmetry. Now, we talked about, this is a cutting balloon post-rotational atherectomy, a small study, 23 patients with balloon angioplasty post-rota versus cutting balloon. Stent expansion was much better, significantly better in this paper published only a few years ago from the Japanese. And so cutting balloon was an independent predictor, even after rotational atherectomy, of calcium fracture, as well as greater stent expansion. This is my study at Liverpool Hospital. We compared rotational atherectomy plus cutting balloon versus IVL and DES. And now this is a mandated IVUS or OCT post IVL. And so the area, the liminal lumen area after just IVL with that additional balloon dilatation was less than rotational atherectomy, significantly less. However, after stent implantation, the stent expansion, it was all pretty much similar, including an MSA. So that the rotational atherectomy plus cutting balloon achieved a larger MLA before stents, but otherwise the post-stent area and stent diameter were comparable. So OPN balloons look a bit better than scoring balloons in the study. And I think that the imaging will go all the way around. And I think that in the end, to summarize, scoring balloons can work if you see it work. And cutting balloons seem to be better than the other scoring balloons, but the data is very scant. And I think we've largely replaced scoring balloons with IVL. And OPN balloons, I think, has a promise, although if you oversize it, it may have a high risk for coronary rupture. So I will stop there. Thank you. Let's have a discussion.
Cindy, thank you very much. I think only Dr. Lucio and Dr. Low Cindy can talk about this topic in this comprehensive way with lots of study. It's very nice and very surprised that seems cutting balloon work pretty well. You don't need the IVL. So I don't know what about the others' opinion about this.
I think there's a comment with those studies. Number one is that I don't know the thickness of the calcium. In fact, if you speak to a Kiko Mahara, even though you see reverberation after rotational atherectomy, maybe it's polishing and you get more reverberation. The question is how thin the calcium is. I don't think you know on the IVUS. And so these IVUS studies don't tell us how thick it is. I've done many studies where I've done rotor and then cutting balloon. I don't think it did very much at all, sometimes nothing. So the question really is that how effective is it? Unless you see cracks, you're probably not contributing. And I think that's why I think it's been replaced largely by Shockwave.
Mm.
It's not the same, Lamco, if you have, and you need to treat superficial calcified plaque or deep calcified plaque. I think when you have deep calcified plaque, IVL is superior, and cutting balloon is a very good technique, but you need to know when to put or to use it. Perhaps after rotablator, maybe very nice. I don't know, what do you think about this? If you can use as a primary modified plaque technique, or you need, for example, rotablator previous to this. In this calcified plaque, no?
Yeah, and I think we've moved a little bit ahead because we're using rotor to get your device in and mostly Shockwave if you need to, rather than cutting balloons. So we probably will never know because it won't be very completely studied in a very good way. So OCT, of course, would tell you, and you have to be very stringent about pre, post, and after to really see a difference. Otherwise, I don't think we understand it very well. So I think that case I show you, just a rotor and cutting balloon, I think there's calcium around, but the lesion was relatively superficial, I think, calcium. And so it looked like a very good result. And therefore, you can I didn't put a stent in it. Yeah.
Could I ask some question, because we don't have much experience on that. How about calcium nodule? What do you think about the effect of scoring balloon, cutting balloon on calcium nodule?
I have tried on IVUS. It doesn't work, I don't think.
Okay.
Because it's right where the blades are. So in that model study, they say if you put 2 blades into the calcium, then it works better, even at lower pressure. But I think that was the original concept. You have less pressure to get a scoring of the plaque. So the calcified nodule is very eccentric. So there's migration of the blades. So the probability is that it's not going to work at all. And the other scoring mechanisms probably the same. It's unlikely to modify it very much.
Okay.
Yeah, actually, if you use scoring NC or cutting balloon in calcium nodule, they do the same. Is they dissect the vessel usually in between the calcified plaque and also the normal segment. So they actually do the same most of the time. So usually, if you have calcium nodule, that's why I would prefer to use ablation or CSI if you want to achieve a greater lumen in the end.
Yeah. The thing in my mind is it depends on the nodule. Would you shock a lot, meaning that it still works? I've seen it work. It will crack a nodule, but the question is that you're still very eccentric, but you might need a lot more shock. So I'm not sure because the thickness might be really high.
Yeah, I don't actually, I try it, but I don't know. I mean, I actually have no crack on the OCT. But of course, there may be some micro crack on high density CT or so. But I actually see no difference on OCT after shockwave on calcified nodule.
Yeah, I've seen a couple of cases done by Zaid Ali and other operators, and they've shocked the nodule, and it has cracked it on OCT.
Yeah, probably you may need multiple cycle of shockwave in order to do that.
The conclusion is that I think that if you have an image to use, you need, and it's 100% to use in these calcified complicated lesions to achieve a lot of information previous to do the plaque modification. You can see if it's more or less 180 or 360 concentric plaque, then to see if superficial or deep plaque, then the length, the thickness, all this information is very important to select the best modified technique, and then to have the better result and the lower complications. So this is a very, very important issue to say as a final take-home message. And if you don't have images, that there are some people that they don't have images, you have to do the simpler PCI in this complex lesion. So I don't know if Lo or other people of the panel can say something as a conclusion of this very nice meeting that I have learned a lot of you. So I appreciate a lot of all what you say, and I will be in Hong Kong if I can.
Okay, great. It's already 3 hours since we started the meeting, so I think it's time to draw it to a close. I think Lucio already summarized it very well. I haven't got much to add except to thank all the speakers tonight and the discussants for a very engaging conversation and discussion. I hope the audience and certainly learned a lot. I learned a lot too tonight. Yeah, thank you everyone. Enjoy the rest of your weekend, and stay tuned for the next TCIP session. Thank you very much.
Okay, good. Have a good evening. Thanks, everyone. Thank you.
Thank you.
Thank you very much.